We are live, sir. We can go ahead.
Okay. You put your disclaimer.
Sir, go ahead without disclaimer.
Okay.
No issue.
So I will share my screen now. Is everything visible? My PPT is there.
Yes, sir.
Please go ahead.
Okay. Good evening, everyone. And welcome you all to Delhi Orthopaedic Association PG training webinar, and theme for today is non-union and malunion. I am Dr. Manish Dhawan and I am moderator of this session, and I work in Gangaram Hospital. Now, first I welcome Dr. Sharad Agarwal. He is president of Delhi Orthopaedic Association and he is senior consultant orthopedics and joint replacement surgeon at Max Super Speciality Hospital, Padpadganj, New Delhi. He is president East Delhi Orthopedic, past president of East Delhi Orthopedic Association, and he has presented many academic papers and delivered many guest lectures. Welcome, Dr. Sharad. Dr. Hitesh Lal is secretary Delhi Orthopedic Association. He is professor at Sports Injury Center, Safdarjung Hospital, New Delhi. And he is a former professor at RML Hospital and also formerly professor at Central Institute of Orthopedics, Safdarjung Hospital. He has more than 100 national and international publications and delivered many guest lectures. Welcome, Dr. Hitesh. I think he will be joining soon. Professor Lalit Mani is editor of Indian Journal of Orthopaedics. He is president-elect Delhi Orthopaedic Association. He is director professor at Maulana Azad Medical College, New Delhi. And he is executive editor of Journal of Clinical Orthopedics and Trauma. He has authored many books, chapters, and has numerous national and international publications and chaired many sessions in national conferences, delivered numerous lectures. Welcome, Professor Lalit Mani. Dr. Barjinder Singh is our co-moderator. He is Joint Secretary of Delhi Orthopaedic Association. He is Senior Consultant Orthopedics at B.L. Kapoor Super Speciality Hospital, New Delhi. Welcome, Dr. Barjinder. Dr. Ravi Chauhan is a very energetic, young, dynamic person. He is our webinar coordinator, and he has designed the concept of this whole webinar, including the flyer. And he works as an associate with me. He's an associate consultant at Gangaram Hospital, and his special interest is trauma and pediatric orthopedics. Dr. Ashok Sham, this whole webinar is possible because of him. He is editor of OrthoTV and he's assistant professor at Sancheti Institute of Orthopedics and Rehabilitation, Pune. He's chief researcher and head of IAORG, and he's editor of JOCR Journal. And he's also EC member for Maharashtra Orthopedic Association. Dr. Neeraj Bijlani is associate of Dr. Ashok Sham, and he's coordinator at OrthoTV, and he's consultant orthopedic surgeon and tech enthusiast at OrthoTech Mumbai Clinic. Dr. Shamshul Huda is coordinator of OrthoTV, and he's consultant orthopedic surgeon at Rajeshwar Hospital, Patna. And our guest panel includes Professor R.K.S. Dhakad. He is president of Madhya Pradesh Orthopedic Association. He is joint director and superintendent of Gajra Raja Medical College, Gwalior. And he has AO Trauma Fellow for fellowship from Germany. He is a joint replacement fellow at Wrightington Hospital, was a fellow at Wrightington Hospital, UK. Welcome, Dr. Dhakad. Professor Saket Jati, he is secretary of Madhya Pradesh Orthopedic Association. He is professor and unit head of Sir Aurobindo Medical College and PG Institute, Madhya Pradesh, Ujjain, in Indore. He is a gold medalist in MS. He has a AO fellowship from Augsburg, Germany, and he is a joint replacement. He has joint replacement fellowship from Germany. He has 23 publications and faculty for various conferences and organized many conferences. Welcome, Professor Saket Jati.
Thank you, Manish sir.
Now I request Dr. Sharad Agarwal, President Delhi Orthopaedic Association, to give his opening remarks.
Thank you, Dr. Manish. Good evening, friends. I welcome you all to the postgraduate teaching program of Delhi Orthopaedic Association. Today's subject is non-union and malunions of the bone. These are complex subjects and we come across them not too infrequently. These conditions are always more difficult and trickier to treat than a fresh fracture. It is expected that we may come across more of such cases in near future due to injuries not getting adequate attention during the lockdowns. Today's webinar shall touch upon some of the salient aspects of these subjects for revision of our postgraduates and to guide them the best approach to handle such cases in clinical practice as well as during examination. We have a galaxy of experienced eminent speakers to broach the subjects and equally senior panelists to discuss with them. I welcome the whole learned faculty who are sparing their valuable time to grace the webinar today to contribute their experiences on the subject. I'm sure the webinar shall be a great learning, revision, and update for all of us. My thanks to whole DOA team, especially Dr. Barjinder, Dr. Manish Dhawan, and Dr. Ravi Chauhan for their untiring efforts in organizing the webinar. Thanks to Dr. Shamshul Huda, Dr. Neeraj, Dr. Ashok Sham for all the technical support. And my thanks to the sponsors of the program, Jidus Cadilla, for their unrestricted education grant. Thank you.
Thank you, Dr. Sharad. I request Dr. Barjinder to please introduce the faculty.
Yeah, let me introduce. Today we have an eminent faculty who are teacher of teachers, and they will be presenting case-based discussion for long and short cases. So let me start with Dr. Sumit Sural. He is a director professor and head of unit at Maulana Azad Medical College. He is a special interest in spine surgery, and he has been an organizing secretary of MEMC PG course for over 10 years. Then we have Dr. Lalit Mani, a young dynamic person. He is the editor of Indian Journal of Orthopaedics. He is the president-elect of Delhi Orthopaedic Association, at present working as a director professor at Maulana Azad Medical College, New Delhi. He is also executive editor of Journal of Clinical Orthopedic and Trauma. We have Dr. P.P. Kotwal, a well-known figure, at present working as chairman, Institute of Orthopedics at Pushpavati Singhania Research Institute, Delhi. He had been professor and head of Department of Orthopedics at All India Institute of Medical Sciences, Delhi. His special interests are trauma and hand surgery. We have Dr. P.N. Gupta with us. He is a professor in orthopedics at Government Medical College Hospital, Chandigarh. He is a special interest in pediatric orthopedics. Then we have Dr. Vikas Gupta, professor at Central Institute of Orthopedics, Safdarjung Hospital. He is working in clubfoot and cerebral palsy patients. Then we have Dr. Maninder Shah Singh, a senior consultant working as chief of foot and ankle services at Indian Spinal Injury Center, Vasant Kunj, New Delhi. He has taken his training and worked at Royal Orthopaedic Hospital, UK also. I will ask Dr. Manish to start the first presentation.
Yeah, I now Dr. Sumit Sural to start his first presentation. He will be presenting on a long case on non-union flexion eczema. Dr. Sumit Sural, please. Dr. Sumit. Dr. Sumit, we can't hear you. Please unmute yourself. Dr. Ravi, just unmute him.
Yeah.
Yeah.
So, good evening. Is my slide visible?
No, sir.
Not yet, sir.
Okay. Is it visible?
It's coming, sir.
Okay. So at the outset, I would like to thank the Delhi Orthopaedic Association for giving me this opportunity to do this case discussion and taking me back to my days as a postgraduate student, because I'm supposed to act as like a postgraduate student while presenting this long case. I will be presenting the history, the examination, and then the diagnosis and the differential diagnosis, or what is the reason for the diagnosis, and the little bit of management, and then I think it will be open for discussion. So I'm presenting a history of Ramlal, a 65-year-old retired man who was a resident of village Dera, who came to us with the presenting complaints of inability to bear weight on the right lower limb for the past 4 months. So the history of present illness is that he was apparently well 4 months back, walking comfortably and doing all his activities of daily living, when he slipped and fell down on a wet floor on 26th March this year, that is 4 months back. And after the fall, he was unable to get up. He was unable to stand and put weight on his right lower limb and walk. So he was lifted up by his relatives, and then he was put on the bed. Initially, he had pain around the right groin, which was quite severe and was continuous without any radiation for the first few days. It was aggravated by movements when he was moving around, trying to turn his posture on the bed, and was relieved only with analgesics. After the severe pain, a few days, then the pain became moderate for the next 3 to 4 weeks, almost like a month, and then mild over the next 2 months. And since the last 1 month, he's been having no pain in the right groin area. As far as his activities of daily living are concerned, initially after the trauma, he was on the bed and he was doing his daily clearance of bladder and bowel on the bed itself initially. And after 1 month, after 3 months, when the pain subsided, he started ambulating with the help of a cane. And then he started going to the toilet and was able to sit cross-legged and squat. Regarding the negative history, there is no history of any massage. There is no history of any surgical intervention or any traction. There is no history of any pus discharge. There is no history of any other joint pain or morning stiffness or any long-term medications like steroids. There is no history of any fever, loss of appetite, loss of weight. There is no history of any cough, sputum, or blood in sputum. There is no history of blood in urine or any vomiting or blood in vomit or passage of black-colored stools. And he has not complained of any swelling in any part of his body. Regarding his family history, there is no history of tuberculosis nor of COVID-19 infection to any of his family members. He is a personal history, he's a smoker. He smokes around 2 bundles of BD every day. His bladder and bowel habits are normal. Treatment history, after the injury, his attendants took him to a hospital nearby and an X-ray was done and it was advised surgery. But due to the pandemic, the patient and the attendants avoided any surgery. On examination, the general physical examination, patient is thinly built, pulse around 70 per minute regular, blood pressure 120/78, and he is afebrile. He has mild pallor, no icterus or cyanosis or lymphadenopathy. The systemic examination shows the central nervous, cardiovascular, and abdominal within normal limits. And the respiratory rate is 14 per minute. His chest expansion is 5 centimeters. Regarding the local examination of his right hip, which is the pathology area, the patient was examined in the lying down position because he was unable to stand without support. So examination standing was not done. Since he was not able to walk without supports, walks only with a cane, the gait examination was not done. He's able to sit cross-legged and squat comfortably without any pain. On examination in the lying down position, on inspection, the attitude is that patient is lying down supine comfortably on the bed. The right hip, knee, and ankle are in the neutral position and parallel to the opposite limb. The right lower limb is external rotated to the extent that the lateral border of the foot is touching the bed. The lumbar lordosis is not exaggerated. Anterior superior spine appears to be at the same level. In the Scarpa's triangle, there are no scars or sinuses. There is wasting of the thigh and the gluteus. The limb appears short as the patella and the medial malleus. Both levels are proximal compared to the opposite limb. On palpation, the lumbar lordosis is not exaggerated. The anterior superior spine are at the same level. The local temperature is not raised. There is no tenderness in the hip joint. The Scarpa's triangle has no swelling. The trochanter has no, the local temperature is not raised. There is no tenderness. There is no broadening or thickening. There is a proximal migration, which has been evaluated by the 3-digit palpation. There is no mass palpable in the gluteal area, whether globular or any other type of mass. And the rest of the shaft of the femur is not thickened. The vascular sign of Narath is negative, and the external iliac lymph nodes are not palpable. Regarding his deformities, there is no deformity in the sagittal and coronal plane. That is, there is no flexion deformity, no abduction adduction deformities, and no rotational deformities. The movements, There's no range of active movement present. All the movements are passive and they are painless and without crepitus. The flexion, all the movements are also more than the opposite limb. The flexion is full with the thigh touching the chest almost more than 140 degrees. The extension is of 20 degrees. Abduction is 45, adduction is 45 degrees, abduction is 50 degrees. And the rotation with the hip in extension as well as the hip in 90-degree flexion shows internal rotation of 45 degree and external rotation of 90 degree. They are all exaggerated compared to the opposite limb. On measurements, there is an apparent shortening of 2 centimeter, and the true shortening is also 2 centimeter, which is supratrochanteric as measured by the Bryan's triangle. The base of the Bryan's triangle is 2 centimeters shorter compared to the opposite side. The Schumacher's line is distal to the umbilicus. The Cheney's lines are not parallel. It is converging on the right side and diverging on the left. The Morris bitrochanteric test is equal both sides. The Nelaton line, the tip of the trochanter crosses the Nelaton's line. On the special test, the Trellenberg test was not done because he's unable to stand on his right lower limb for more than a few seconds. The telescopy test is positive. Active SLR test he is not able to do. The Dassault sign is positive. The Alice test of the Galicis sign is also positive, with the knee appears more proximal compared to the opposite knee when both the knees are flexed and the feet are together, flexed to 90 degree. The rest of the examination, the perrectal examination shows no abnormality. There is no distal neurovascular deficit. There is no distal swelling in the right lower limb. The opposite hip, both the knees, both the ankles, the spine, and the sacroiliac joints are within normal limits. So with this history and the clinical findings, my diagnosis is a non-union fracture of the neck femur on the right side. So the questions which are likely to be posed in the exam is: number one, what is your clinical diagnosis? Is there any differential diagnosis? And what are the, on what basis do you give this diagnosis? And what is the management? So diagnosis from the history and examination is the non-union fracture neck femur. With this history and clinical findings, I have not kept any differential diagnosis. And what is the reason for the diagnosis? So for that, the points for diagnosis is in the history that after the trauma, he was not able to bear weight on the right lower limb. He was not able to get up, stand, or walk, and he was lifted up. And his activities of daily living, as well as the pain, sequentially over the past 4 months, his pain decreased, and now there's no pain at all. And he's still unable to put weight on the right lower limb, and he's not able to walk without a cane. However, he's able to squat and sit cross-legged, and that is also without pain. From the examination, the relevant positive findings are on the attitude of external rotation to the extent that the lateral border of the foot is touching the couch. There is no tenderness, so that means it appears to be non-union. Again, from the history, the pain had come down, there was no pain, so both of these findings are towards the diagnosis of a non-union. And the fact that there are no active movements, even the active SLR is not possible. However, there is a good range of painless movement, which is more than the normal, especially the rotations and the abduction adduction, and it is painless. Also, there is a telescopy sign is positive, frank telescopy is there. The shortening is only 2 centimeters, not more than that, and it is supratrochanteric. And I have not kept a differential diagnosis because the relevant negative findings of the trochanter being not thickened or irregular or tender, and there is no mass in the gluteal area. With these points of history and examination, my provisional diagnosis is a non-union fracture of the neck of the femur on the right side. So what is the management? Now the management will, although in this case, in this particular case, I've put as 65 years old, but I was told by Dr. Manish that it's better that you discuss management a little more than that particular case. So the management of fracture neck of femur non-union will depend quite a lot on the age of the patient. And it's not the chronological age that we're talking about the physiological age. So for example, this person, he's 65-year-old man. Now, whether he is a 65-year-old man, which is the chronological age, and it is matching to his physiological age, that it could be that the man is so frail, thin, and it's not like a 65-year-old. Whereas at the same time, there could be a person who's 65 or above and who would be walking around, even jogging or playing tennis, or doing his activities of daily living comfortably. So physiologically, his age would be probably lesser than 65. So depending on the age of the patient, we decide whether we need to preserve the head or we need to sacrifice the head, right? So in the elderly, well, what is elderly? So physiological age above maybe 70 or so, we go ahead definitely for an arthroplasty. Between 60 and 70, then again look at the physiological age, look at the amount of osteoporosis, because you see, if you're trying to preserve the head in not so elderly or in the younger, so there are all the factors that you are aware of, that why a fracture neck femur goes into non-union, right? So here already it is non-union, and then on top of that there is an osteoporosis, right? So if there is osteoporosis, then the chance of any surgery that you're doing is the chance of success of a surgery is very doubtful, right? And in an elderly, we want the patient to be up and out of the bed because lying in bed, you have all the complications of bedriddency, including whether it's bed sore, DVT, or even get orthostatic pneumonia, or sometimes even people who are the elderly people on bed, they sort of get psychologically distressed that I'm doomed now, I'm only bedridden. So in the elderly, we want surgery which has got a definitive result, and of course in today's day, arthroplasty. Now regarding arthroplasty, whether it should be hemi-arthroplasty or a total hip arthroplasty, so the older the age, definitely it's a hemi-arthroplasty, and if it's a younger type of elderly, then you go for a total hip arthroplasty, because the patients would likely to be more active, and there's more likely of failure of a hemi-arthroplasty than a total hip arthroplasty. So in the young patients or who are physiologically active elderly, we would like to do an osteosynthesis. Now we are talking about diagnosis of non-union. It's not as a fractured neck femur fresh. So in a non-union, to preserve the head, so that means what are the options? So one is not just fixation like in a fresh fractured neck femur, you need to augment it, right? So now augmenting, so it all depends upon, so maybe a postgraduate student can go on to a Sandhu's classification of stage 1 and 2, maybe you can preserve the head, and stage 3, you need to sacrifice, right? So that is in the elderly, but we're talking about the young. So in to preserve the head, we could use vascularized bone graft, the Mayer's procedure, the quadratus femoris muscle pedicle graft, or the tensor fasciae lata, which is better than a sartorius because of its dual blood supply. And fibular grafts, both closed reduction in fibula, open reduction in fibula. I mean, what I'm talking about closed reduction, obviously that means we're talking about free fibula. And of course, there could be vascularized fibula. But the question which is posed in the exam is, what are you going to do, right? So it's not what is given in the literature. In the exam, you as a candidate, you will be answering that only the procedure which you have seen or you're confident with. So I have not seen a vascularized fibular graft being done. And doing a vascularized fibular graft is difficult and challenging, because you see you need to harvest the graft along with its vascular pedicles, and then to pass that graft through the making a hole in the neck and the head, and without kinking of the blood vessels, it's technically demanding. So I in an exam would not definitely say vascularized fibular graft. Now osteotomy is a very safe answer for head preserving, and even in the presence of avascular necrosis, the valgus osteotomy can be done. If I was a student, like when I was a student 25 years back, I would have confidently said McMurray osteotomy, because we used to do it so frequently. But nowadays, I wonder whether any of the postgraduates have seen this procedure, and it's not being done for the simple reason that because after this displacement oblique osteotomy, which is displaced, there is a problem doing a total hip replacement later. So that's why more and more surgeons are discarding McMurray osteotomy. However, it is a good option. And in cases where in the Sandoz classification stage 3, where there is a resorption of the neck more than 2.5 centimeter, or there is the proximal fragment is very small, or where the avascular necrosis is there, right? So there is a very difficult chance of retrieving. So in those cases, even the Powell VY osteotomy can be done. So it is little different from the Powell's valgus osteotomy, where for doing the valgus, wedge is removed from the lateral aspect, going on to the medial shaft of the femur, whereas in a VY, the wedge is only till half the shaft or 2/3 of the shaft, causing a V there, and the rest is like a Y. So VY osteotomy that is supposed to recreate the neck a little, which is sort of absorbed. So it depends upon the candidate, what answer would you like to give, because I would recommend the candidates to read even the Indian Journal of Orthopaedics. There is a good article, which is a review article by Dr. Anil Jain, which talks about all these procedures, and there could be a even combination of procedures, especially in the fixation, the combination of fibula along with the quadratus femoris bone graft, or fibula with McMurray, or whatever. So there could be a combination of all these. So we need to look into the avascular necrosis part, because even with most of the candidates feel that it's avascular necrosis, so it's established. So obviously you cannot do a vascularized bone graft completely to revascularize it, though people have done it. And there are reports of it had been revascularized to some extent. But I think in today's day, valgus osteotomy is also a safe answer for this. So I think I end here. Yeah.
Thank you, Professor Sural, for such a beautiful case presentation, because this is required for the postgraduates. Professor Dhakad, can you hear me? Professor Dhakad, can you hear me? Okay, then I go to Professor. Yes.
Can I stop sharing?
Yeah, sure. Professor Dhakad, are you there? Dr. Saket Jati.
I'm online, Manish bhai. Yeah.
Sir, you are now examiner of Dr. Sumit Sural. What questions you would like to, ask if in the history, or any comments about his presentation?
I believe most of the things Dr. Sumit had covered. The only thing is that as far as learning of the postgraduates are concerned, the attitude of the limb and vis-a-vis the differentiation between the non-union or neck femur or the trochanter should have been there. Dr. Sumit.
Yeah, so at the end I did mention, during my examination also I mentioned regarding the trochanter. So the trochanter, as mentioned, was not thickened, irregular, which would have happened in case of a fracture which had occurred in the trochanteric area. And in the trochanteric non-union, it's not a frank telescopy for the students. There might be some amount of a crepitus also while trying to do a telescopy in a non-union of a trochanteric fracture. Yeah. Yes. And in a trochanteric non-union, sometimes because trochanteric fractures, the shortening is more compared to intracapsular fractures. So this was only 2 centimeter shortening. So that would have been more than 2 centimeter shortening.
Fair enough. I think Dr. Sumit had covered almost all the points, Dr. Manish, which should have been there so as to ask to the student.
Okay.
Can I ask a question?
Yes, sir. You can.
Dr. Sumit, I would say very crisp and excellent presentation. But where will you put imaging in that? Do you expect that student to confirm the diagnosis by any kind of imaging, or will you not talk about it at all? Or you will show X-ray that this you explain the X-ray? I mean,
Yes, yes. Thank you so much, Dr. Sharad. And that was something I missed completely. So, because actually I was just doing more on the examination part. So, as you rightly said, when the examiner, actually this happens automatically when the examiner is asking a question. So, what will you do next? What will you do next? So, in that part, when you come to the diagnosis, then after that, what diagnosis I gave was a provisional clinical diagnosis. And as you rightly said, the final diagnosis would be after the radiology. So X-rays and especially X-ray in internal rotation to look at the profile of the neck, X-ray pelvis with both hips, with the right hip in internal rotation and a lateral view. And sometimes in the exam you are asked about how soon can you find out avascular necrosis, right? So this is a question which is asked. Since you're talking about investigation, I thought let me add on to this. So it is said that by plain radiograph, it may take from 6 months up to 2 years for avascular necrosis to be detected on plain radiographs. So regarding MRI, yes, MRI can show the avascularity at a much earlier time. And especially there are papers, especially about the dynamic MRI. Now, the dynamic MRI is a very specific procedure which actually very few orthopedic surgeons know about. It can be done on any MRI machine, but most radiologists are unaware or they don't want to spend time doing it because there is a software which, you give a gadolinium dye and from the fractured neck of femur from that side, you compare with the opposite side. But after giving the dye at different times, a graph is drawn. And then from the graph, you get an idea whether it is vascular or not. So vascularity can be found out by dynamic MRI even on day one. Otherwise, bone scans may be required for early detection of vascularity of after fractured neck femur. So yes, you're right. I did miss the X-ray part. And thank you for putting that in.
Dr. Dhakad, can you hear us?
Yeah,
Dr.
now,
Dhakad, yeah, you are, Dr. Sumit has given his presentation. So what are your comments about his presentation and any questions for Dr. Sumit?
actually, it was huge disturbance connection. So he presented a case of fracture neck of femur, I think.
Yeah.
Is it?
No, we can take you, we can involve you in the next case if you have not heard.
Yeah, please.
Okay, Dr. Sumit,
Yes.
there are a couple of questions for you from the audience. What is the need of asking blood in stools and blood sputum in negative history?
Yes, I purposely put those things in because you see, an elderly person falling down could be whether it's we usually take it as an osteoporotic fracture, and it said that in the osteoporotic fracture, the patient because of the fracture falls down rather than falling down and giving a fracture. However, at this age, we would like to rule out a pathological fracture. So when I'm going to go through the list of causes of pathological fracture, so I've included everything. So pathological fracture or severe osteoporosis, starting with even other joint pains. So what is the relevance of other joint pains? Yeah, so maybe the patient is a known as a known case of arthritis on steroids, very osteoporotic, right? So we need to know that for the management also. Or it could be maybe some underlying pathology and there is a metastasis. So to rule out the primary, so all those questions were asked, starting with first whether any loss of weight, loss of appetite, with then everything for the primary, whether any hematemesis or melena or any swelling in the part or any cough, and especially when he's a smoker, so any cough with hemoptysis. So all those questions were asked gearing onto that. Yeah, thank you for asking.
Okay, Dr. Sumit, can we say non-union or ununited if the history is less than 3 or more than 3 months? When do we say that? And what is the more appropriate terminology to use?
Yeah, so there are various terminologies. One is ununited, one is neglected fracture, because apparently there was no treatment given. So it is a neglected fracture. So usually, by 3 weeks, fracture neck femur, we are not talking about, now if it is neglected, then all fracture neck femur except the impacted type, may unite, but otherwise all of them will go on to non-union, right? So, well, after 3 weeks, you could say ununited. You could use the term ununited. After 3 months, definitely you could start using the term non-union. There are even the review article of Dr. Jan in the IGO talks about neglected fracture neck femur, right? For whether it was 3 weeks, 3 months, or more than 3 months. So these terms are various, people use different terms, and I don't think it's just a splitting of hair. So maybe Dr. Kotwal or other senior panelists could give their view regarding this also.
Dr. Kotwal, please.
Yeah, Sumit made a very good presentation. Obviously, he covered most of the points from the examination point of view. From the students' point of view, I'll just like to ask one question to Sumit. Sumit said that in the imaging, X-ray, of course, is very useful. It gives the diagnosis, all right. And then also about mentioning about the MRI to know the vascularity. I would like to know, Sumit, is there any role of CT scan that you would think the student should know about?
Well, for a fracture neck femur non-union, I usually would not go for a CT scan because everything is very clear on the X-ray, and at the most you would like to know about the vascularity, so that would then come from the MRI. So unnecessarily giving radiation of a CT scan, to my mind, is not required.
So, Dr. Sumit, there is a question related to this only, that should we need to tell MRI in the investigation to rule out AVN, or only X-ray is enough?
Well, so you see, this was a fictitious case presentation, you know. So in the exam, it always goes how, you see, and I have seen a lot of exams, it doesn't even go till the discussion. Okay, so it all will depend upon what questions are being asked and how it is going on, right? So when the appropriate question is asked, you have to answer appropriately. So if it is asked about the MRI, you answer about it.
Hi, Sumit.
Not on day one. Yeah.
Sumit, can I ask a question?
Yes, yes, please.
Yes.
Yeah, very comprehensive presentation. The only point I want to ask, suppose if you want to salvage the hip, so what additional investigations would be required other than the X-ray? Now, the patient was 65. Suppose patient had been 50 years. So what the student must know that along with the X-ray and you're contemplating osteotomy,
yeah.
so,
So
is there any role of any
good question?
Yeah.
A very good question. So basically, regarding the regarding the investigation, so we already discussed X-ray and MRI. I'm not going to that. One additional thing, at the age of 50, you would like to know the osteoporosis. So maybe a DEXA scan would be an investigation there, because am I audible?
Yes, sir.
Yeah. So a DEXA scan at that age, because when you're trying to put in an implant, and you would like to know whether the implant is going to hold on to that. So that is the additional investigation that I would put on to X-ray and MRI. So
probably CT also, to see the amount of neck or the length of the neck.
So
in a like a young patient with a fracture neck femur.
You see, I wouldn't go. Fair enough on X-rays. I don't know. I have never done a CT till now for any fracture neck femur non-union, and because for the simple reason, unnecessarily I don't want to give radiation, because my management can easily be done by the Sandhu's classification on plain X-rays and with MRI.
Okay. Dr. Sumit, what should we say if patient has pain and NTN joint tenderness in this case?
Yeah, so you see, there are some, I made this fictitious case very simple for discussion. Now, there are different patients who can present different ways. Maybe at 3 months, there could be some amount of tenderness. There could be some amount of pain even while attempting to walk. So it all depends case to case, but definitely after 4 months and 5, 6 months, the tenderness tends to go down. However, if there is tenderness still, and that is the question being asked, and then you could even think of other reasons. And one of the reasons is myositis ossificans, because a lot of people get massage done, right, in our country. So now when the myositis is in the immature stage, it could be tender, right? It could be painful, but once it mature, so then the tenderness would go off. So that is one additional thing.
Okay, Dr. Sumit, can a student say in exam that he is unable to do Trendelenburg test? You have already mentioned that he is not able to, but can we say that I have not done Trendelenburg test?
Yes, when there are certain criteria for doing it, when the patient cannot stand on the right lower limb for more than 30 seconds, you cannot do the Trendelenburg test. But however, there could be a question after that, can you do something else? Then you can answer that I have done an indirect Trendelenburg test, right? So I have not mentioned that here purposely because only when the examiner will ask, then only I will tell about it.
Okay, Dr. Sumit, you mentioned about some special tests like Ellis test and Destot test. Are they really necessary to be told in exam?
Well, the salt sign is done for a hip examination, especially it's a good sign for non-union of the neck femur because the arc of movement when you're rotating the limb is not the simple, just the arc in the normal limb, but it is increased. And the Alice test and all, you may mention, you may not mention, but in the special test, it comes in the special test. And since there's a shortening of 2 centimeters, so it's okay if you mention it, like I've mentioned it.
Dr. Sumit, is active straight leg raising test important here in ununited
It's
fracture
extremely important. So among the special tests, in fact, diagnosis is coming from these special tests, whether it's a telescopy, whether it's active SLR, because active SLR, that means he's not able to lift his limb. That means there is a discontinuity there, right? So that is definitely a very, very important test to be done.
Professor Hitesh, you had a question for Dr. Sumit?
Answered by Dr. Surar only. I was just asking, is the PG expected to tell MRI before envisaging treatment in a non-union fracture neck femur 40-year-old?
Yes, thank you, Dr. Hitesh. So as I mentioned, the student should not say anything. He should not volunteer to say too much. Let the examiner ask the question. So let the student start. What investigations will you do? I'll do plain radiographs. Then the radiographs will be shown. Then if they ask, okay, what will you do next? Then you can go on, right? So you should not volunteer and give. Here, this was a fictitious case presentation. So I did also the X-rays, but in the exam, you are just, you have to reveal one by one when the questions are asked.
Sumit?
Yes.
Yeah, how useful is the vascular sign of Narat?
Well, vascular sign of Narat, a good question that you've asked, is, I think, one of the most, what should I say?
But not
confusing test, because you see, what is vascular sign of Narat? It is basically you're palpating the femoral pulsations against the head of the femur, right?
Yeah.
But you see any case. So when, for example, the femoral head is not there in place, like a dislocation of the hip, the vascular sign of Narat is supposed to be positive, right? But you see, even if there is nothing there, whatever the underlying tissue, the moment you press the, palpate the femoral pulse, you will put your fingers a little deeper in, and there will be some resistance or something, and you will feel the pulse. It's very, very rare that you are not able to feel completely at all.
I think we should compare with the opposite side. I think that will be more.
That is why it is compared, and when it becomes feeble. So complete absence is a very, very difficult. I mean, I have not seen even in dislocated completely absent. So it becomes feeble.
Yeah.
So that is why I said this test is very, sort of confusing.
Dr. Vineet, you had a question?
Yes, thank you everyone. Very good evening to everyone. Dr. Smith, nice presentation. And I just want to know one thing. First of all, is the patient is able to do straight leg raising test possible? Because sometimes it is because of fibrosis, we always call it a fibrous union. And does the treatment modality changes in that condition? Whether it's whether we should change some kind of fixation versus replacement, or in case if it is not like that, so is there a role of MR angio if we want to decide before taking up whether replacement or fixation versus osteosynthesis?
Yeah, thank you, Dr. Vineet. So yeah, there are some patients. What happens is after fracture neck femur, there is some sort of a fibrosis, and even the capsular, fibrosis, some sort of thing occurs, and the patients are able to do active SLR. But that active SLR, please remember, the students should remember, is not the normal active SLR. They're just able to do maybe 20, 30 degrees or maybe a little more, but they're not able to maintain it for a long time. right? So it really does not change your management at all. And regarding the angiography, well, to my mind, angiography is not needed. The main thing is to see the vascularity. So for that, the other investigations like I mentioned about the gadolinium, so dynamic MRI rather than an angiography would be more important. Yeah.
In some patient, if the patient is able to do the 70-degree or 80-degree of sustained as active SLR, so should we leave it like this one without doing any osteosynthesis or replacement with that patient?
Yeah, so it's all now case to case. Now, a 4-month-old non-union is unlikely to have 70-degree SLR. Very, very unlikely. Now,
no,
what you are describing,
in general.
Yeah. So what you are describing is not a non-union case of 4 months duration, or so it's possible that sometimes you see now if it's an impacted fracture neck femur, right? Some of these impacted fracture neck femur, they unite by themselves also, right? But you have to be very careful that initially when you see the patient comes in and the patient is able to do the active SLR, right? And you get an X-ray done and you find that's an impacted neck femur, then you should not allow the patient to do active SLR, right? Because that is going to create more forces onto the hip joint. And it's not advisable to do active SLR, rather you either give a splint or something, right? So so now regarding a question of doing active SLR, you need to correlate that with the radiographs. Now, if the radiographs are showing absolute non-union sort of a picture, right? Obviously, it would be a stage 1 of Sandhu, right? That he's able to do active SLR 70-degree. So if it is a completely, I mean, it's a fracture, then it is always better to do a fixation unless it is an impacted fracture. Okay. Some people like to do fixation, even in situ fixation, even in impacted fracture.
Okay, Professor Mani, can you be ready with your presentation? By the time I will take 2 questions. Dr. Hitesh, you had a question?
Yes, sir. If a patient is 40 years old and the duration is 6 months, and if he is having pain, is the PG right in saying that the probable cause is avascular necrosis?
Well, avascular necrosis causing pain per se, because this is not an avascular necrosis in an intact head, intact neck, right? So now what happens is, now there is, if there is a other cause of avascular necrosis without a fractured neck femur, then you could be having pain. But 6-month-old, there may be some amount of pain due to some reasons, but pain would not be a major presenting complaint, right? So because it's already 6 months and there is a disruption in the neck, so we don't expect the AVN to cause pain.
Professor Sumit, can you explain about the hip biomechanics in Trendelenburg test?
Oh, then that is going to take time.
I think we'll take it later.
I already did that. I already did that in my hip presentation. In
yes,
the DOA.
Yes, I think that is better.
Yeah.
I think we go forward now. I request Professor Mani to give his presentation on malunited entrotrochanteric fracture. Professor Mani, please.
Thank you, everybody, and welcome to the guest state, Madhya Pradesh, my friends, Dr. Dakar and Dr. Saket. Now, I think Sumit has done an excellent job and covered quite a few topics, which I will have to repeat in my presentation. So I'm presenting a scenario of a malunited intertrochanteric fracture. I would add few facts as we go along the journey of seeing this case, which would clarify how things present in a patient. So now, as in any other case, we would be basing our treatment on 3 things: history, examination, and management. Now, as already told, if you do your history and examination well, you've done things very well, meaning you've already done 60 to 70% of a good job. And the management is further divided into investigation and treatment. So the 2 small pics on the right side give you a bird's eye view on what we do in a history and an examination. Let me remind you about the anatomy of the hip joint. The top figure shows you the anterior and the posterior view, and you can see that posteriorly, the capsule is not totally covering the neck of femur. So there is some area which is deficient. That is what
produces non-union at times in intertrochanteric fractures, meaning if a line is oblique and is exiting posteriorly, it can have a neck femur component even in a trochanteric fracture. And the serial pictures on the lower down, you can see the various types of described trochanteric fractures. From left to right, there is an increasing degree of instability which is coming in. And as we know, and as it is described in literature, the medial buttress caused by the lesser trochanter is one of the important factors, which if is broken causes a varus. There is another factor that there are huge muscles attached to the shaft of the femur, both on the medial side and on the outer side, which pull the shaft upward. There is a weight of the limb which takes the whole of the lower limb outward in external rotation. And all these get together and create an unstable situation which causes a classical varus external rotation deformity. Another concept which has come in recently is the lateral wall. So we've talked about the medial wall. Another one is the lateral wall. If the lateral wall is too thin, it is one of the factors which contributes towards an unstable trochanteric fracture. Beyond these would be the reverse obliquity ones and the transverse ones and the ones which extend into the subtrochanteric area. They are adding on to the instability within this fracture. So when the amount of instability increases, the probability of malunion increases. So let's get on to the job history. Now we start with the patient profile as already described. There is a mnemonic with the name of SORMA, meaning name, age, sex, occupation, residence, marital status, and when was the patient admitted with you. So all this tells you about the background of a patient, what could be the positive issues in the patient, and how you're going to manage him later on after giving him treatment. The presenting complaints, you need to know the onset, the duration, and the progress. And the two main presenting features in a malunited trochanteric fracture would be a limp, and the second one may or may not be a pain. So the usual complaints in a malunited trochanteric fractures are a deformity or a limb shortening. There may or may not be some amount of limitation of movements. There might be inability or difficulty of bearing weight. Pain may or may not be there. There might be some amount of swelling which might the patient complain on the outer aspect of the upper thigh. And definitely the gait of the patient changes from what he had before injury, and that is what he described as a limp. Now that limp could be unaided or aided, meaning that he might be using some walking aid for moving around, or he would be walking without any aid. So we need to know about the onset, the duration, and the progress of each symptom in chronology, and then describe the history of presenting complaint. I will come to a few classical examples in my subsequent slides. We definitely need to know the pre-injury status, which has a bearing on making the diagnosis as well as deciding what would be the treatment. We want to know the mode of injury, whether it is a low energy trauma or a high energy trauma. And in a malunited trochanteric fracture scenario, the treatment history is pretty important. Negative history we've already talked about. So if there is pain, now in a classical malunion, there would be no pain. So what is malunion? It is a scenario where there is a faulty or a fracture which unites in an inadequate, inappropriate way. So there should not be any pain. However, there could be scenarios in which due to the malunion and consequences of the malunion, there is pain. So what could be the cause of pain? It could be bony impingement. It could be soft tissue impingement. It could be fatigue due to the inefficient abductor lever arm. It could be secondary changes coming into the hip joint because of the changed biomechanics of the proximal femur, like degenerative arthritis could start. or at times even avascular necrosis could set in. So if the patient has pain, you need certain extra things to be detailed. The site of the pain, classically in a hip pain, the patient will point towards the anterior side of the groin or slightly on the side of the groin. You need to describe the character, the intensity, and the radiation. If there is pain in a trochanteric malunion, invariably it is a mechanical pain, meaning it is going to be dull, it is not going to be throbbing or very severe. It could be activity related. There could be some amount of gelling when a patient sits for too long. There could be radiation towards the medial aspect of knee. So if there is pain, you need to go further into pain, because hip examination is like mathematics. If there is a symptom or a sign, it needs to be evaluated completely to complete the puzzle. So let's see a few case scenarios. A 60-year-old female slipped at home, could not get up, had to be lifted and taken to bed due to pain in the left hip. Now this patient could not walk for 8 weeks, was in bed, and started walking with a walker after 2 months as pain decreased. He presented to us at the end of 1 year of this injury as a painless limp with shortening of the limb, but can still ambulate with a walking stick. So now you can see I have described the patient mode of injury. Was it a significant trauma? This is a very, very important question asked all the time. What is the definition of a significant trauma? That means after the injury, the patient could not walk. He had to be lifted and taken. And beyond that, he could not carry on his activity of daily living as he was before injury. You need to describe, you need to come out with a progress in time, and then the presenting complaint could be of various types. One I have told you is a painless limp, and the patient is ambulating with a walker or a stick. The second scenario could be everything same. Again, it is 1 year end, but there is a painful limp with shortening of the limb, but he can still walk around with a stick. So now this patient probably is more demanding than the previous one. He's come to you in the OPD because there is some disability which is coming in due to pain, which has disappeared earlier, but now again appeared. Now, both the previous patients did not get any treatment, so they will come into the category of neglected trauma. Now, the same patient, if he got treatment with surgery and started ambulating with a walking aid gradually and gradually left his walking aid, and he comes to you at the end of 1 year with a painless limb with shortening of the limb and can walk around with a walker or a walking stick. So this is another scenario where treatment has been taken. However, the patient complains of a painless limb. Another scenario, same treatment taken, but he comes with a painful scenario. So now these two categories could fit into a failed treatment. That means although the patient was given treatment for his problem, but he comes back after 1 year with a disability, signifying that there is a failed treatment. So to summarize these multiple type of scenarios which can happen with a malunited trochanteric fracture, it could be an old age patient. I'm trying to emphasize that there might be a bimodal distribution. I'm not talking about pediatric fractures. They can occur in pediatric age group also, but we are discussing adult patients right now. So there is a bimodal distribution, meaning that these are fractures of the old age. They could present with painless limb or painful limb. They could present with history of treatment or history of no treatment. So they could have a presentation at 3 weeks, 6 weeks, 12 weeks, and they would fall into different categories as described earlier into neglected, delayed, or failed treatment. Now, as emphasized earlier in negative history, whenever you have a patient who is old age, you need to look into the comorbidities, which could be general or specific. Meaning you want to rule out any causes which could have caused this fracture, or you want to look at any other problems the patient has which can affect the outcome when he is given treatment. So the next bimodal distribution, it could be a young adult. Now the old age patients are invariably low energy trauma, and the young patients are invariably high energy trauma. It could be a fall from a tree, it could be a road traffic accident. Again, the scenarios could be similar. Painless limp or painful limp, treated or untreated, and the timelines accordingly. Now, in a young patient, you are bound to look at other injuries. Because why should a young patient not get treatment? Lockdown could be one of the reasons, but then there could be that the patient had a severe head injury for which he could not be given the most appropriate treatment which was required. So his hip fracture got neglected. At the end of the history, you again need to end up with a assessment of functional disability, which if you divide it into sitting, walking, what has happened to his occupation, and any specific activity of daily living you think was important in this patient, or the patient comes out himself. In sitting, both squatting and sitting cross-legged is important. It gives you about some idea about what is the level of disability in this patient. So now your history is completed, and you should be ready with this question. Your examiner would interrupt you and ask you what is your provisional diagnosis. So if the patient had pain, it is an easier provisional diagnosis. It will move towards a post-traumatic arthritis. But if the patient has a painless limp, it becomes a difficult provisional diagnosis to spell out, and you need to practice this. And this is one of the suggested ways in which you can present a painless limp in a malunited trochanteric fracture, only based on history. Mind you, this is only based on history. You've only completed your history. So based on history, it is a case of neglected trauma of the left hip region leading to limb length discrepancy in a 60-year-old female. Further examination is required to ascertain the condition more precisely and decisively, because it is very difficult with just the history points to pinpoint towards what could be your actual anatomical diagnosis. But you need to be ready with this statement, because this is a standard protocol. At the end of the history, you're asked about your provisional diagnosis. So obviously, if it is such a scenario, you're going to get away from the question of a differential diagnosis at this point of time, at the end of the history. So now we'll run through the important points of examination in a malunited trochanteric fracture. Most of you should make a habit of creating a performa of examination of whichever region you are, so that you don't miss out anything and you follow a particular sequence. So as in any other case of a hip examination, you will do examination standing. So standing and sitting, you need to describe things which are possible only on standing and sitting. And the important points would be the level of the anterior superior iliac spine, the knee, and the ankle. Now in a trochanteric fracture, you know there's going to be a short limb. So be careful how the patient is standing. In examination, when you're presenting a case, at times the patient stands with an equinus, at times he is standing with a flat foot, at times with a flexion of the knee of the normal side. So please describe what is visible when you're presenting it during your presentation. If there is pain and there is an adduction deformity, your anterior superior iliac spine could be at different level during standing. And if the patient is standing with a flat foot, your anterior superior iliac spine would be at a different level. From the side, the lumbar lordosis can be commented upon. From behind, you need to comment upon the scoliosis, the posterior iliac spine, and the gluteal wasting and the gluteal fold asymmetry. As you can see in the two pictures shown on the side, you need to be very, very vigilant about the things you are looking at. If there is a scoliosis, there is a subtle deep crease in the torso on one side. The torso upper limb distance is different on the two sides, and positioning of the limb is different. So you need to inspect all three regions, the hip region, the knee region, and the ankle region. because you know in a malunited trochanteric fracture, there is going to be shortening and you need to describe how the patient is standing. A gait would have either a short limb plus Trendelenburg or short limb Trendelenburg with an antalgic component. So it is going to be a complex gait, and a classical thing which might be there is an out-toeing. Because of a severe external rotation malunion, the patient could be walking with a severe out-toeing. So if it is there, you need to be describing it. And when you present a case, please make all your markings. If you have marked your spine, if you marked your posterior spine, the examiner gets the message that you have done it. So if there was scoliosis on standing, you have to definitely do a sitting test whether it disappears or not, and then move ahead to the examination on supine position. The first part would be inspection. You look for exaggerated lumbar lordosis. More often than not, it is not there in such cases. Level of ASIS, if there is an adduction deformity, it could be higher. If there is only limb length discrepancy, it will be at same level. Any fullness in the Strauss triangle. Be very careful about scars. Now, what we are observing is that you will get more and more cases in the exam in which already surgical intervention would have been done. So if there is a scar and you have not described an inspection, you have done a major miss. So you need to look for a scar for a PFN or a DHS, and be very careful if the patient has been managed by conservative treatment, you have described in the history, and you have not looked for a scar for the upper tibial Steinman pin. So these are important points of observation which you need to bring out. Wasting, if it is there, it is glaring and you should not miss out. It needs to be conveyed. Level of the knee and the malleoli and the attitude of the limb, and I had told you before, there will be severe out-toeing. It is said that the out-toeing is much more, if you compare it with a fractured neck femur, it will be more in trochanteric fractures than in a fractured neck of femur. So classical wasting, you cannot miss this out. If you miss this out, it's a problem. And there is a peculiar type of an abnormal shape of the proximal thigh, which you can observe in this patient. The proximal thigh is more outward and prominent in the upper part, which is due to the malunited varus orientation of the proximal femur. Palpation, you again look for the level of the ASIS. In obese patients, at times it is not very well visible, both the ASIS and the medial malleus. So you reconfirm your findings of inspection. The first two things you do are local temperature and tenderness. And this tells you whether you're dealing with an acute condition or not. That tells you how gentle you need to be in the further examination. So this point was discussed earlier also about tenderness. Now, tenderness could be there if there are secondary changes which have started due to the altered biomechanics, if arthritis has started, or if there is surgical intervention which has been done in patient and there is some implant failure happening, there is some intra-articular migration of a screw or something. If there is a subtle infection inside, that could be a cause of pain. And in non-union scenarios, like in fractured neck femur, due to repeated upward and downward movement of the trochanter, at times there could be repeated minimal trauma and synovitis there, which can produce tenderness on anterior hip joint tenderness evaluation. Vascular sign of Narath is going to be negative, and it is very important to look at the trochanter. In a malunited trochanteric fracture, probably evaluation of the trochanter in inspection palpation is very important. How do you localize a trochanter? You palpate the shaft of the femur. How do you palpate the shaft of the femur? You gently roll the lower limb and feel where the femur is, and then gradually go upwards. And you will feel a bony prominence starting, which is the trochanteric area. So that is one of the ways to localize trochanter. And once you've done that, you start looking at the other features. The first thing would be tenderness. As I told, if the patient is between 3 to 6 weeks, the patient could still be tender. And if it is not tender, you know that it's a very well consolidated malunion. You need to palpate the surface. There would be irregularity of the surface. in a classical trochanteric fracture. You need to palpate the trochanter in the anteroposterior direction and compare it with the normal side. So the thumb on the anterior side and of fingers on the posterior side gives you an idea on the width, the anteroposterior width of the trochanter. And you can easily make out a difference when you compare it with the normal side, both on the surface as well as on the widening. There can be another type of widening, which is on the mediolateral aspect, which is very, very difficult to assess on clinical evaluation. One indirect way could be the Morris test, but then the Coxa vara also contributes towards a positive increased length in a Morris test. You will do the digital Bryant triangle to give you an estimate at the time of palpation on a proximal migration of the trochanter. That's the way how you palpate the trochanter. And you can see there are scars. So if there are scars and you have missed them out, it's a major miss. You marked your 3 points. Now the 3 points, 2 are bony points and 1 is an imaginary point. So it gives you an idea. You compare it with the normal side. And once you finish your palpation, you next move on to deformity evaluation in sagittal, coronal, and rotational plane. There might not be a sagittal plane deformity. Maximum, there could be a minimal amount of flexion deformity due to secondary changes in the hip. There would be a coronal plane deformity, which you have already been told how to evaluate. An adduction deformity is one of the associated deformity. And you have malunion and various grades of external rotation. So you should practice evaluation of rotational deformity in extension, in flexion. Prone evaluation is a very nice way of evaluation because you can easily evaluate both the limbs at the same time. So do practice this part in a prone evaluation, because in hip you invariably forget what all things can be done in the prone evaluation. So once you mark your deformities, then comes the range of movement. In wherein the flexion extension would be okay. There could be some limitation of extreme flexion because of bony impingement, because of the varus position. The classical restriction is an abduction because of the coxa vara. And then the trochanter is malunited in external rotation, and both the internal and external rotation could be limited at times. So please, when you do your movements, it is not a bad idea to request the patient to do it for you first, and then you do it on the normal side, and then you come to the abnormal side, and always be very watchful about any spasm or capitus being elicited. This would be very important when a pain is associated, any surgical intervention is done, you're expecting maybe arthritic changes happening, or there is an implant inside which could be migrating in the joint. So you need to be very watchful about the crepitus and the spasm. So if there is a deformity associated, the way of describing is 10 degrees adduction deformity with further 30 degree of adduction possible on the involved side. And remember the deformities which are there in a trochanteric fracture. Once you've done your deformities, you do your apparent and your true measurements. And it is a nice thing to convey whether there is a shortening or not. Meaning you need to say either there is 4 centimeters of shortening and there is no difference between the true and the apparent. The second scenario could be there is a shortening, but there is a difference in the apparent and the true shortening, meaning that the apparent shortening is 5 centimeters and the true shortening is 4 centimeters, signifying that there is a coronal plane adduction deformities. At times, the students go on describing the length, 80 centimeter on the right side and 79 centimeter on the left side, and they do it for the apparent and the true, and then it gets a bit confusing. So it's not a bad idea to share the shortening and whether there is a difference between apparent and true. And for measuring of the true shortenings, you need to square the limbs. And the second prerequisite is both the limbs need to be measured in the same position. So again, reminding you, don't forget posterior prone position evaluation. in a malunited trochanteric fracture, the only positive thing could be a gluteal wasting. The only good thing you could pick up is evaluation of an extension, reconfirming there is no flexion deformity. So special tests or other tests which help you at the end on coming and concluding your diagnosis. I have marked telescoping as first because this straight away takes you away from a non-union. So if telescoping is present, it takes you away from a non-union, it takes you away from a neglected posterior dislocation of the hip. Now Trendelenburg test, a classic malunion of the trochanter, there will be a positive Trendelenburg test. However, if there is an adduction deformity, that means there is a coronal plane deformity, the abduction is not possible. So there would be a fallacy in the Trendelenburg test, and you have to come out in the exam that since there was an adduction deformity, I have not done the Trendelenburg test. This is one of the reasons few of the examiners expect the Trendelenburg test to be done at the end as a part of the special test. And because by the time you have completed your evaluation, you have an idea of coronal plane deformity and you don't get entrapped into fallacies. The Craig's test is for anteversion. Now in trochanteric fracture, there is severe external rotation malunion. So the anteversion will have a hit, but you need rotations to be possible to test this. Active SLR is a very, very important movement to be tested because active SLR, if it is present, takes away pathologies in which the fulcrum is broken. So which are those pathologies? Fracture neck femur, posterior dislocation hip, the two classical examples which are taken away. And this active SLR is a confident active SLR and easily done till 70 degrees. So re-emphasizing the Bryant's triangle, the trochanter goes down posteriorly and proximally. So the base will get shortened. It is a good idea to measure it on both the sides, and both the perpendicular and the hypotenuse would increase. The Shoemaker line, important measurement again. So as you can see in the schematic diagram, the dotted line is showing when a coxa vara happens. So the line will intersect below the umbilicus and on the opposite side. The Nilaton's line are done in a lateral position with a flexion of the hip, and the tip of the trochanter goes proximal to the Nilaton's line. And re-emphasizing the measurements have to be done when there are two measurements by squaring the pelvis and putting the limb in a similar position. So if you have to summarize, a malunited trochanteric fracture, on inspection, there is an externally rotated lower limb, almost the outer aspect of the foot touching the bed. There is a short limb, which is a significant shortening, could be of the range of 4 to 5 centimeter. There is a prominence in the upper lateral thigh. If it is an old case of a 1-year duration, there would be wasting. Palpation will come out with broadening, irregularity of the trochanter and proximal migration. Movements, there would be decreased abduction, external rotation and extension, and active SLR is positive, telescoping is negative. Invariably, it is a supratrochanteric shortening. The Bryant's triangle is classical, and in a classical malunion, the Trendelenburg test should be positive. So at the end of the history and the examination, now you will pull in all the data that you have collected. And if it's a pure malunited, non-complicated case, a nice way to frame the diagnosis would be a neglected, malunited intertrochanteric fracture of the left side in a 60-year-old female with 10-degree adduction deformity, 4 centimeter true shortening, and no neurovascular deficit. As we have been taught, there has to be all the components in a diagnosis: the anatomy, the etiology, and the pathology. The next question immediately, do we have a differential diagnosis? If there is a surgical intervention, everything gets changed. So if your history and your signs are not fitting in, and it is a surgically intervened case, even a non-united fracture neck of femur will fall into a differential diagnosis. If it is a painful hip, again, a secondary traumatic arthritis fits into, and there is a huge list on that. However, if it is a plain and simple malunited trochanteric fracture, you still need to have certain things in your mind. It could be rarely a malunited subtrochanteric fracture or a cervicotrochanteric fracture, both of which could come into a term like a pertrochanteric fracture. There could be a case of a congenital or acquired coxa vara whose history of fall was insignificant, and he's come to you after a few years. So you need to look at all those diagnoses in your mind. So just don't be very blank with what else could be. Because classically, what the patient is presenting you is an altered proximal femoral anatomy. So try to rethink all the causes from congenital to developmental to post-infective to classical fibrous dysplasia and osteomalacia or Paget's or just a trochanteric giant cell tumor. So if a differential diagnosis is asked, be ready with it and fit it as your patient comes in. So you would be asked what a coxa vara is because the whole anatomy in this patient is a coxa vara. So when you're born, your neck shaft angle is around 160 and gradually it settles down between 120 and 135. Anything below 120 is coxa vara, and different books says different. Anything more than 135 or 140 is a coxa vara. So management, two parts, investigation and treatment. I'll be very brief here because it has been covered, most of it. So investigation, whenever you are asked, straight away go to X-ray pelvis with both hips and a left hip lateral view. So the next thing is, okay, put up the X-ray. While somebody is looking for the X-ray, you might be asked why an X-ray. So the clear answer is to confirm my diagnosis. Anything else? Yes. Look for the status of bone quality, the joint, the head, the status of the fracture union, any other pathology as a cause which is underlying, any implant placed due to previous surgery. And then this set of questions could end with a question, if the X-ray is lost and it cannot be traced, okay, what is expected? What do you think will be seen in this patient? So please imagine before you come to your presentation that with your history and examination, your provisional diagnosis, what are you expecting in the X-ray? So now here is the X-ray. So whenever X-ray is put up, please take a pause. Please look at it completely and then start describing. The classical way is from periphery to center. So if we have to describe this X-ray, this is an X-ray with pelvis with both hips. The upper part of the pelvis is not completely visible. The exposure is adequate. The pelvis is in an oblique situation, meaning it is not placed in a proper situation for an X-ray. This is important to convey because if a patient is tilted and oblique, certain signs could come up like an unequal obturator foramen seen in this patient. So this is important to say. And then you can start with the iliac crest. The supraacetabular bone quality is comparable. The joint line is less clear as compared to the opposite side. It is a bit fuzzy. The head is resorbed and half the size of the other side, and it is irregular. The neck is foreshortened and it is very close to the tip of the trochanter. The trochanteric size is less. The lesser trochanter cannot be made out. There is a gap between the medial neck and the teardrop. The lesser trochanter, whatever is visible, is too close to the ischial tuberosity. The shaft is not visible on the outer aspect because of an implant, a dynamic hip screw, which has collapsed a bit, and it is also intra-articular. It is fixed to the shaft with 4 screws. So you need to practice describing the X-rays. And another scenario, a neglected traumatic malunited trochanter with a degenerative hip. You can have another scenario where surgical interventions have been done, but the hip joint is okay. So few words, last 2-3 slides about what the treatment could be. Now the treatment could be depending upon the age of the patient and the disability of the patient. If it is a painless limp with a 2 centimeter shortening in a 75-year-old patient who has reached to his pre-injury mobility inside his house, I would reassure him and maybe give him some amount of a shoe raise if it is acceptable to him, and recall him for a reevaluation after a few weeks. Now, the other scenario could be that there is too much of a limp. It is coming into the activity of daily living and it is fatiguing him. There is a lot of shortening. So if it is a young patient, you want to see whether a reosteosynthesis is possible. There are times, as I have seen in these two cases, there is a possibility of a reosteosynthesis, or the classical answer is a valgus osteotomy, as is also a solution to a ununited fracture neck femur. In an elderly patient, or if the joint has got damaged or the head got resolved, a replacement arthroplasty is a solution. The second scenario, which is going to be there in your exam, is an already intervened patient with an implant inside. So in such scenario, please do not forget infection, which could be a cause of a problem. So you need to keep it in mind. You need to add investigations preoperatively, the blood markers to pick up any investigation, any infection, and then it needs to go through an algorithm in which, if you suspect infection, you have a two-stage procedure where you do implant removal, debridement, and antibiotic bleed. Or if you don't suspect that, you look at the head, if it is destroyed or it is saved, and you have three main options. Either you replace or you preserve the hip. If you have to preserve the hip, you have two possibilities. You might have a possibility of a refixation, or you might have a requirement of an osteotomy. So what happens in a coxa vara? Since the trochanter moves up, the neck shaft angle decreases, the biomechanics are changed. So what you do in an osteotomy, you try to take out a wedge from the outer aspect and recreate the anatomy. So depending upon the amount of wedge you take and lateralize the shaft you do, you will gain length in the same procedure. So now osteotomy is another seminar and symposium in itself. We cannot cover it here, but malunited trochanter is a scenario in which you are specifically correcting the biomechanics of the hip. So you need to start getting into the practice of drawing diagrams, making tracings, cutting them. And the best scenario could be...
Professor Mani, can we speed up?
Yeah, I'm just finishing. So if we draw our tracings, do our cuttings, and if we have 100% X-ray, you can actually use your implant and superimpose and see what's happening. So to summarize, your case needs to be evaluated on the pillars of history and examination. If you've done them well, you're almost there in doing a good management of the patient. Thank you very much.
Thank you, Professor Mani. Thank you very much. Professor Dhakad, any comments or questions for Professor Mani?
Sir, this is fantastically covered. Not everything, all the aspects has been covered by Professor Mani. Dr. Mani, see, it's always one question at the time of diagnosis in undisplaced fracture, trochanter, and intracapsular fracture neck of femur. This most of the time this question is asked. So see how this telescoping test is beneficial for to make a difference between both of them.
And that's a very, very relevant question in a hip injury case. And I assume that we will never be getting an acute case in an exam. So what we are dealing with is invariably a case which is between maybe 8 to 12 weeks and the pain has settled. So now if there is a break in the fulcrum, that means if there is an intracapsular fracture neck femur, if you do a telescoping, you will be able to move your trochanter up and down. However, if it is a minimally displaced trochanteric fracture and you've already passed maybe 8 to 12 weeks, this fracture is almost uniting now. And if you try to attempt to do a telescoping, it will be negative. So this becomes actually a keystone between differentiating between one side, which could be a neglected dislocation or an ununited neck femur, and the other side, it could be the gamut of malunited fractures of the upper region.
Professor Saket. Professor Saket.
Yeah.
Yeah, question or any comment for Professor Mani?
I think Professor Mani has covered it most explicitly. The only thing is, Professor Mani, would you like to ask the student a bit detail about the gait of the patient?
Yes, the gait is one of the most important parts in the exam, and in fact, we had done a PG session in which gait was a separate lecture. So gait is an important part. It needs to be described. In fact, we even insist if the patient is using a walking aid, then you describe it with the walking aid. But this part can never be missed out. And you can actually form a sequence of describing. You can go from top to bottom. That means from the shoulder to the toes or toes to the shoulder. The description is very important in the swing and the stance phase. And at the end, you need to maybe, if possible, summarize it in one of the classical ways of classical types of gaits.
Which would be relevant for the differential diagnosis, I believe.
Yes. One thing which is there in malunited trochanteric fracture is a mixture of a short limb and a Trendelenburg gait, because the abductor lever arm is inefficient and the limb is short. At times you're asked how do you say that both are there? So one of the tests is that you compensate the shortening, give him a shoe raise, and then make him walk. And what happens is the Trendelenburg component actually becomes even more, because the short limb part has been taken care of, and the main thing now which is happening is the sway. So this is one thing which the student should know.
Dr. Mani, can I just add something?
Yes, sure.
Yeah, I mean, the easiest way to actually put a shoe raise is ask the patient to take off the shoe on the normal side and wear on the affected side. So that's the quickest test which can be done in the OPD as well as if you really don't have a shoe raise.
Yeah, well taken point, Professor P.M. Gupta. Professor Mani, why there is more shortening in IT fracture than in fracture neck of femur?
Why there is more shortening? So now you need to understand the anatomy. If you imagine the size of neck femur, probably it varies between say 2 centimeters to 3.5 centimeters. And if you imagine the size of a trochanter, it would be in inches. So it could be from 2 to 4 inches. So the area itself of the two regions is different. And now when you have a fractured neck femur, and it is already an old fracture neck femur, the capsule and the other things have healed. And if the neck is not resorbed, it is resorbed to only maybe Sandhu's type 1, the maximum the trochanter can move is maybe 1 or 1.5 centimeters. However, in a trochanteric fracture, there is no such control. And in fact, there are so many strong muscles which are pulling them up, and it can lead to a large amount of shortening.
Professor Mani, in a case of malunited subtrochanteric fracture with limb and recent pain of arthritis, what are the management options?
You said malunited subtrochanteric.
Malunited subtrochanteric fracture with limb and recent pain of arthritis.
So I hope it is a young patient and it is a recent early arthritis. My aim would be to correct the malunion. Now, the modality in a subtrochanteric fracture malunited would be to do an osteotomy and correct it with an implant which is a stable or a rigid implant, meaning that you should not be using a sliding implant. So the treatment in a young patient with early arthritis and a malunion subtrochanteric is an osteotomy and correction with a stable implant.
Okay, Professor Mani, what is the difference between broadening and widening of trochanter?
These are interesting terms, and it is at times that you are taken into a trap. So remember, when trochanter is like a cauliflower, and when it bursts in all directions. So it's globally increased in its volume. I had described that you can easily palpate the anteroposterior width. Okay, so that classically is taken as broadening. Some people call that also as whitening. But if you want to split the hair, you can make broadening as anteroposterior and widening as a mediolateral. So, but clinically, it is just not possible to palpate mediolateral. So to go around this, people say that you can do the Morris test, in which you measure the length from the surface of the trochanter to the symphysis and compare it on two sides. But there is a fallacy because there is a coxa vara, which itself will increase this distance.
Okay, Professor Mani, is there any clinical method to differentiate between the non-union neck femur and malunited trochanteric fracture, like broadening of trochanter? This is one question. You have already, this is the continuation of this thing. And there is another question, what is the relevance of bitrochanteric tenderness, if any?
So you see, what happens at times is that you have an antalgic gait and you are struggling to elicit any tenderness in the hip. So there are various methodologies which have been described to elicit tenderness of the hip. Now, once you do an anterior hip joint tenderness, you're actually going directly on the hip joint, the hip capsule, and maybe the underlying synovitis. And when you are going from the trochanteric side, there could be two problems. There could be a tenderness in the trochanter, and also there could be a arthritis in the hip. So in both cases, the tenderness is going to be coming positive. However, if there is a trochanteric pathology and you do a hip joint tenderness, it's going to come negative, and direct trochanteric tenderness is going to come positive. So these are 2-3 tests which are done to rule out whether the problem is in the hip joint, in the trochanter, or at times it could be somewhere in the middle in the neck.
Okay, Professor Mani, is there any importance of fracture posterior part of the neck not being covered by capsule?
Yes, that is what I am trying to convey, that if in an exam you get a patient with all the findings of a trochanter, broadening, shortening, huge, everything, and then you have a telescoping positive, there are trochanteric fractures which will be a 4-part or a 5-part, in which there is a head and neck fragment which behaves like a intracapsular neck of femur, meaning it starts from the trochanteric region, ends up into the neck. So even in a trochanteric fracture, you are at times asked questions. Is there a possibility that there can be a non-union? And what are the possibilities? There are two possibilities. One, when there is a component of a fracture neck femur in it, and the other when there is a component of a subtrochanteric fracture in the trochanteric fracture. So these two scenarios can contribute towards a non-union in a trochanteric fracture.
Professor Kotwal, please be ready with your presentation. And when you are getting ready, I'll just take the opportunity to Dr. Hitesh Lal wants to ask a question.
Dr. Mani, it was a meticulous presentation. How do you expect a postgraduate to measure the wide broadening of trochanter? By a vernier caliper or a tape?
I think we've not done this. We actually do a digital palpation and it gives us a assessment. But if you want to go into a nitty-gritty, you can use a flexible tape to measure that. For that, you'll have to mark the anterior and the posterior border of the trochanter. And remember, the trochanter has moved posteriorly. So it might be a good idea to do this measurement in the lateral position.
Professor Some people also mention the trochanter is thickened. Should you use that? How to use these terms objectively?
Be smart. Use your words judiciously. Palpate the pulse of the examiner. What are they actually trying to extract? One thing I wanted to add from the previous lecture, if I'm asked what could be one of the indication of a CT scan in a fractured neck femur, my indication would be assessment of union when there is an implant inside. So you could get a case in which there is already a CCS inside, and that could be one indication to do a CT scan.
Okay. Professor Kotwal, please.
Yeah, shall I share my screen?
Yes, sir. Yes, sir.
see? Is it?
Yes, sir. It's visible,
Yes,
sir.
sir.
Right. So, good evening. From the long case, we go on to a short case of non-union of a distal radius, which may actually be given as a short case in the examination. And before I start doing that, I would like to express my gratitude to the to Dr. Sharad Agrawal and Dr. Manish and the team DOA for giving me this opportunity to participate in this webinar. So, Malunion of a distal radius is actually very common, and the incidence reported is anything from 5% to 70%. And however, it has also been described that when treated surgically, the incidence of malunion reduces to about 10% or even less. And this has also been seen that in cases where the corrective osteotomy is required to treat the malunion, the 80% of the cases are the ones where the treatment has failed, which has actually been a conservative or a closed treatment, whereas the remaining 20% actually are the ones which have had failed osteosynthesis, particularly either the treatment has been by X-fixed or by K-wires. Before we go on to understand the malunion, we need to recapitulate the anatomy. This is the normal X-ray and the normal anatomy of the distal radius and the wrist. There is a radial inclination, which is of about 23 degrees with a range of 30 to 30. Then the radial length, which is the radius is longer by about 11 millimeter. So the stick tip of the radial styloid is, and the radial styloid and the ulnar styloid, the difference can be anything from 8 to 18 millimeter. The average is 11 to 10 millimeter. And there is a volar tilt of about 11 or 12 degrees, which is on the volar side. How to understand or how to make out which is the volar side? There are two things that about it. That one is the thumb that you see. It is on the volar side, and the second thing is the metacarpals. The dorsal side of the metacarpal is flat, whereas the volar side is actually a concave thing. So any of these things which you can, or both of the things you should be able to differentiate which is the volar side and which is the dorsal side in a lateral view. So whatever the treatment which is employed, and this has been a case of a fracture of the distal radius which has been healed, the treatment goal should be that the radial inclination should be more than 5 degrees at least. If it is less than that, then obviously it is not the correct direction of the fracture. Then the tilt should be at least either the neutral or maybe a little plus on towards the volar side, because that's the normal anatomy. The length must be restored, as we saw that just now. Then the gap between, if there is a fracture, this should be less than 2 millimeter. And if there is a step off in the articular surface, it should be less than 1 millimeter or less than 1 millimeter. And the DRUJ should be stable. Now we look at the displacements of a distal fracture of the distal radius. That's the classical X-ray. The first and this thing is there is a proximal impaction. Look at this, the radius is short now as compared to the ulna. Then there is radial deviation. All the carpals and this thing are now deviated radially. So this is now causing radial deviation because of the proximal impaction as well. Then you have the dorsal displacement. This is the dorsal side again by this thing. This is the thumb, which is on the volar side. And that's the concavity of the metacarpals, which is actually facing the volar side, and that's the straight border of the more or less the straight borders of the metacarpal, which is on the dorsal side. So there would be proximal impaction because of the shortening, which will cause the shortening. Then there is radial deviation, which will lead to a deformity. We'll come to that, and then you have the dorsal displacement. This is the dorsal displacement. You can see here, that's the dorsal side. This is the carpals which have been shifted dorsally, and that's the fracture fragment which has caused the displacement of the carpals on that side. This is now united, and this is united with a dorsal tilt. So this is the malunited radius fracture, which is there is a dorsal tilt. Sometimes, less commonly, there can be a volar displacement also. This is the volar side, and because of the fracture here onto the volar side, the carpals have all translated onto the volar side. So this is a classical malunited volar displaced fracture. What you should be able to see in this is a malunited. You can't see the fracture line here. Number one, there is definitely a difference in the articular surfaces. In a normal X-ray, you would see the articular surface more or less in one line. There will be a little second one also, but this is now you can see here. You can't see the clear-cut radiocarpal joint here. The radius is short. The ulna is definitely longer, and you can see here this is the volar displays more or less like a volar, must have been a volar button fracture which is united here now. The lunate is displaced volarwards. Now it should have been sitting in the saddle of the distal articular surface, which has now come forward along because of the displacement of the fracture fragment on the volar side. So this is actually a malunited volar displaced fracture. How does the patient present? Obviously, following a history of injury, fall on the outstretched hand about 3 or 4 months back, which treated or perhaps not treated, which is the scenarios are possible in our setup. So they present with, and how do they present after 3 or 4 months after the injury? They present with pain, then with loss of movements, restriction of movements. The restriction of movement can depend upon the direction of the displacement. That means whether there is a volar displaced fragments, the distal fragment is displaced volarward, or whether it is displaced dorsalwards. We have seen both the examples, both the X-rays, and also upon the magnitude of the deformity. How much is the displacement which has not been corrected by treatment? Then obviously, sometimes an ugly cosmetic deformity. Then the decreased grip strength. This is actually an important presentation, and this is also an important consideration for deciding this actually it makes an indication for surgery in case of malunited distal radius fractures. And in very late presentation, there can be arthritis also, particularly if there has been an incongruity of the articular surface. And as I said, the gap on the step off is unacceptable level, then it can lead to early osteoarthrosis, and the patient can present with pain and the symptoms and signs of arthritis, but that would be late in the day. The causes of pain, if it is the fracture site, this is generally a rare presentation, but this can be because of either the fracture is not united fully, number one, or if there is a joint incongruity in the articular surface, and that is also a cause for pain at the fracture site. Then the pain can be during wrist movements, which actually may be painful because there is a residual stiffness, and if one trying to move that, then it can also present as pain. The common, of course, is the ulnar sided wrist pain. The patient complains more about pain on the ulnar side of the wrist rather than on the fracture side or on the radial side. Then the pain can also be because of median nerve compression, and this is also a known complication or a sequelae, particularly in fractures of the distal radius and the displacement. It can sometimes cause compression of the median nerve. And sometimes if the patient presents 3 or 4 months later, then sometimes they develop CRPS also, complex regional pain syndrome, and this can actually be there. And the reported this thing is that if the external patient has been treated by an X-fix or an immobilization longer than about 6 to 8 weeks, and then of course there are certain other criteria as well for patients who are likely to develop CRPS, but then in that case the patient present with pain and stiffness because of the CRPS, that must be recognized and must be treated accordingly. So what are the causes of ulnar-sided wrist pain, which I said is a commoner presentation? One is, of course, there is associated sometimes fracture of the ulnar stolide, which actually might have not united. And generally, the usual current trend is that not all fractures of the ulnar stolide need to be fixed, even if you are fixing the fractures of the distal radius. And sometimes the ununited fracture of the ulnar stolide can become a site of pain. Then if there is an injury to the ulnar collateral ligament, and which is actually because generally it heals up if the fracture is being treated adequately in an immobilization or otherwise, but if not, then it can also be a cause of the pain. Then the another situation is and what is called as an ulnar abutment syndrome, and which means that what happens is that this is the malunited fracture of the distal radius. The radius is short, the ulna is long, and now with every time the patient tries to do the ulnar deviation, the ulna, it impinges against the lunate or sometimes against the trachetrum, and this causes pain, and which is actually called as ulnar abutment syndrome. Then this can be because of the TFCC tear also, because in situation like this kind of fractures and this can definitely be a cause, and of course because of the longer ulna, and there is an associated DRUJ instability that can also be a cause of the pain. So these things must be looked into the examination, the clinical examination, in the sense that you would try to elicit the cause of the pain by trying to do an ulnar deviation, whether the pain comes because of the ulnar deviation, and so on. And of course, you all need to also test the stability of the DRUJ by trying to move the distal end of the ulna and do the Bellotment sign and piano heel sign. This is a different topic altogether, so we're not going into the details of that. But these are the causes of pain, and they must be looked into while you are examining the case. So this is an example of a DRUJ instability. Obviously, that's the radius, and this is the ulna, which is actually subluxed, and you can see the prominence of the ulna as seen on this clinical picture. Then, as I said, the pain can also be because of median nerve compression. And these are the cases which are likely to where the nerve is likely to be dented over the stretched because of this fragment. You can see this is the distal radius fragment, and this is angulated that much, and so now the nerve is passing like this, and this is likely to get stretched and would present with pain because of all the signs of carpal tunnel syndrome or the median nerve compression. The nerve fog deformity generally is described for acute fractures. We all teach the students that the clinical thing is nerve fog deformity. But sometimes, even in a malunited fracture of the distal radius, and the deformity is gross, which has not been corrected at the time of treatment, and this is united in this position, this can also be a clinical sign of an examination for a distal radius malunion. Then the another deformity is as I was talking about, the restriction of movement. The restriction of movement will also depend upon the deformity and the degree of the extent of the injury. And this is the manus valgus deformity, because what is now happening is that the ulna is longer, the radius is short, also it is radial deviation. So now the wrist hand is deviated to the radial side, and it is obvious in both the pictures that the patient has a manus valgus deformity, which is obvious and should not be missed. The restriction of movement other than this, and again we take up this scenario, you can see here a malunited distal radius fracture. This is the volar fragment here, which is united. Now this is again the carpus displays a little more volar side. It's not exactly in its saddle in the center of the radius. And you can imagine here, if you take this scenario here, this is the one, the volar side of the radius is because of the dorsal tilt here. This is longer. So this is likely to restrict mechanically the palmar flexion. So this is very obvious that the palmar flexion will be restricted, and this also a longer ulna would restrict the ulnar deviation. So the ulnar deviation will be restricted. You can see this is the normal wrist, and that's the wrist on the affected side where there has been a malunited fracture, and the wrist is slightly already in the radial deviation, and it cannot even take that to the ulnar side as much. So there is definitely a restriction of the ulnar deviation. then there will be restriction of palmar flexion, as I told you just now. The same patient, because of this, there is restriction of palmar flexion. So look at the affected side, and that's the normal palmar flexion that he has. See, remember, the patient may have a full arc of movement that you have in the wrist, but the direction of the arc has changed. So there may be a little more dorsiflexion and certainly less palmar flexion, but sometimes there will be a genuine restriction of the palmar flexion as well. And this is an example of the same patient where there's so much of restriction of the palmar flexion. But look at this. Look at his dorsiflexion, which is actually quite good. Maybe a very limited 5-degree limitation of the dorsiflexion, but the palmar flexion is grossly restricted. So the another sign would be the restriction of movements in a malunited fracture about the ulnar deviation and the palmar flexion, and also the rotation, because that will be because of the subluxation or instability of the DRUJ. So this would be the clinical findings signs in an examination. The patient can present, as I said, with CRPS after 3 or 4 months of injury, and this is how the difference will be. The patient will have, this is the affected side, that's the normal side. You can see there is definitely all the signs of CRPS, there is swelling, there is shiny skin, and these restricted movements. Look at the normal side, he can make a fist, whereas on the affected side, there is hardly any movement possible. He cannot really make a fist. So this would be a cause for his pain and restricted movements, as you can see clinically clearly see in this picture. And this must be suspected. You know, the patient has up to 3 or 4 months of this thing. And the best way to do is to do a radioisotope bone scan, as you know, there has been a publication about this thing, and which actually shows an increased uptake in the radioisotope scan in the affected side. And the treatment here would be to continue with physiotherapy despite the pain and the stiffness. And obviously there are other agents for treatment about the sympathetic ganglion block, and sometimes some people like to give steroids for a short time orally also, and so on and so forth. So this is actually in the examination, one must be in the clinical examination, one must suspect this, and this can be because of the CRPS as well. So in the investigations, the strict PA and lateral X-rays are important. We have seen so many examples of PA and lateral view, which is showing the displacements in the fracture. Then sometimes you also need the X-ray of the other side to be able to see what is the normal volar tilt for that particular patient, and the radial inclination, and so on and so forth, to be able to see how much is the extent of the displacement. CT sometimes is important to get to know the how much is the displacement. If one is planning to do a corrective surgery, corrective osteotomy or something, then CT is definitely of use. The MRI generally is required if you are suspecting some other soft tissue injuries as well, like ligament injuries, or which also, if there is, sometimes there can be a scaphoid dissociation and so on associated with fracture of the distal radius. And if that is suspected, then the MRI may be required. And orthoscopy is also as a very important tool in trying to see the anatomy, the joint, and trying to work out the other associated injuries, particularly the soft tissue injuries and so on. So this is how the CT scan will give you an idea about the displacement of the fractures. And this is again the lunate has now shifted volarward, and this is not sitting into the saddle, and there is a die punch fragment also must have been there. So this is actually helps to decide you whether you need to do an osteotomy, whether it should be a volar osteotomy or a dorsal osteotomy. We'll come to that shortly. So what are the types of distal radius malunion? It can be an extra-articular or an intra-articular or a combination of both. For example, this is an extra-articular malunion. So the articular surface is intact. This must have been a kind of a classical Colles fracture, and this is all intact. So the deformity and the angulation is in the extra-articular area. This is a dorsal tilt, and a proximal impaction, radial deviation, and so on. So this is a very classical example of a malunited extra-articular deformity. This would be an intra-articular whatever Malunion deformity, because you can see here there is a step here in the articular surface, and similarly in the DRUJ also there is an instability. So, and there can be a combination of both. There can be a fracture here as well, and then including the intra-articular components. It can be a combination of both. So the treatment, in majority of them, it is symptomatic. They don't require surgery or anything for that matter. And the symptomatic treatment actually mostly in the form of physiotherapy exercises, trying to improve the range of movement, and that helps to reduce the swelling and stiffness to a larger extent, and treat the specific problem. If you have been able to identify an underlying problem, whether there is a CRPS or whether there is a pain because of the carpal tunnel syndrome, nerve compression, and so on and so forth, or an ulnar abutment syndrome, so then the underlying pathology must be treated. And then obviously, if there is a specific need for any of these and it's not being helped by the conservative treatment, then surgery is indicated. But is surgery required often? The answer is no. We can see this here. This is an example, a case scenario of an 82-year-old lawyer. This is a 60-year-old fracture that he had, and this is the range of motion that he has today. I mean, at the time of this thing, and so this is generally a reasonably functional range of movement, and therefore, you should be able to treat the patient and not the X-ray. So if this patient certainly does not require surgery, although the X-ray may look so grotesque, there is everything. There is DRUJ instability, there is so much of tilt, and maybe early onset of osteoarthritis and everything. But then depending upon his symptoms, then one should be able to decide treatment. Then when should you operate? Pain due to gross incongruence in the radiocarpal joint. Loss of grip strength. As I said earlier, the grip strength is an important indicator. Loss of grip strength is an important indicator for surgical distinct correction, particularly because if it is due to a gross malunion of the distal radius, limited range of motion, which is affecting the day-to-day work, and maybe less commonly sometimes because of the cosmetic reasons if the deformity is too grotesque. Been a mechanical study that the 10 degree of palmar tilt is actually puts the load on the ulna, which is about 21%. And if the degree, the dorsal tilt, as is usually there, we saw so many cases, there is a dorsal displacement and dorsal tilt, and the tilt becomes to about gross about 45 degrees, then the load through the ulna increases about 3 times. So that is also the cause for the pain on the ulnar side of the wrist, and this is as per this particular study. So they actually then this becomes an indication for doing the corrective surgery. So the corrective surgery would be an osteotomy, which can be done on from the volar side, or on from the volar aspect or the dorsal aspect, or it can be multiplanar also, and fixation of the osteotomy without a bone graft, depending upon the situation. So this is a malunited fracture where this is on the dorsal side, so the angulation is on the dorsal side. So one can go in from the dorsal side, do a take out a wedge and do a corrective osteotomy and restore the length as well as the neutral rotation of the distal articular surface. Then there can be, even there is, as I said, the more common is the dorsal tilt. Even the dorsal tilt, I gave an example of an osteotomy through the dorsal approach, but it can also be done by the volar side. If because there is going to be a large fragment, the osteotomy would be done somewhere here. And with these days, we have those locking plates. So even this can also be fixed by a locking plate from the volar side. So this is the intraoperative pictures, and this is the corrective osteotomy, correction of the deformity by doing a volar sided plating. Sometimes, you know, this all the time the osteotomy is not required. Sometimes there are relatively minor problems, so they can be corrected or treated by the salvage procedures. And the commonly employed salvage procedures are the Darax procedure, the wafer resection, ulnar shortening, and Sauer-Kapandji procedure. So these procedures are particularly, they shorten the ulna, whether by the direct procedure, I'll show you the pictures, by the direct procedure or the wafer dissection or ulnar shortening. So this is actually done for a longer ulna, which is causing pain, ulnar abutment syndrome, or a DRUJ instability. So these are the procedures which are done to shorten the long ulna. And this is a procedure which is done, I'll show you that also. There is a pain and instability in the DRUJ. So the Darax procedure is a very commonly done procedure. And for example, this is a situation where the ulna is long and it is likely the cause of the pain. Then any of these procedures can be done. There are definite specific indications. We'll look at them. So this is the in a scenario like this, you know, there's instability, long ulna, and so on. This is a malunited distal radius fracture. So somebody did an Darax procedure. That means excision of the lower end of the ulna. This is actually at one point in time was considered as a very commonly done procedure. Most of the times the resident would do that, and earlier also this is a very commonly done. But now with understanding, it is not considered as a very good surgical procedure, as a very good operation. And the reasons because what happens is that when you excise the lower end of the ulna, what happens is that this segment of the ulna now, the distal end of the ulna, it becomes unstable. So now there occurs a distal ulnar stump instability, which is actually quite high, and this causes problem, and the incidence is about 8 to 50%. And therefore it requires stump stabilization. So you should not leave that floating, then it is likely to cause more problems. And therefore it is not recommended in young patients who demand on the wrist is high. And this may be these days, in today's understanding, this may be indicated in older patients, particularly with rheumatoid arthritis, but not otherwise. So one time considered as a very good and a very commonly done operation, this now has selective indications for it. And
Dr. Kotwal, can we wrap it up?
Oh yeah, sure.
Falling short of time.
So this is actually a distal end cut. So you take a tendon from the ECU and try to stabilize this. And this is the example, the same patient, you had done the make holes into this and stabilize it with the tendon. The wafer resection is when there is a very slight increase in the length of this thing and it is causing ulnar abutment. We just take out a small wafer of bone so that it comes in line with the this radius, and now this is not likely to impinge upon the radius. This is a longer ulna shortening done with a newer these kind of plates, and obviously this although because of osteoporosis got loose, but the osteotomy had united, and therefore this screw was removed. And this is also a commonly done procedure, better than the Darax procedure, where you don't excise this and you do an osteotomy proximally. And this is a procedure where there is some pain and the instability in the sigmoid notch in the DRUJ. Then you do a Sauer-Kapandji procedure where you fuse this distal end of the ulna and create a gap, a pseudo joint, so which will facilitate the supination pronation. And this is how you can get good results at the end of the work. This is a 12-year follow-up, good results after a good surgery and a follow-up. So to conclude, this is actually quite common, malunited distal radius. Majority can be treated conservatively. The function should be judged, which if it is acceptable, then do nothing. Surgery is required in selected cases. Otherwise, it may require some salvage procedures. Okay. Thank you very much for your attention.
Thank you, Professor Kotwal, for such a nice presentation. Professor Saket Jati, any comments or questions for Professor Kotwal?
I think Kotwal sir has covered everything The only thing is, sir, I learned a good thing about the only procedure. The rest of the procedure we were doing it. The nicely explicitly shown what all procedures can be done. Thank you, Manish, sir.
Dr. Vineet.
Thank you very much, sir. Thanks, Dr. Kotwal, sir. It's a very nice presentation. So I just want to know a few things, like as far as CRPS is concerned, do we need to take the radioactive test, a radioisotope test always, just to make it confirm this diagnosis? Or shall we treat the patient with physiotherapy without even getting this test done?
That's a good question. This is required for diagnosis, because once somebody gets CRPS, the whole clock is set back. It's going to take a long time. It will take about 3 months or for that thing to settle. It will settle of its own. It will take 3 to 4 months. You will have persistent pain and limitation and all that, as I said already. And in the treatment these days, you have to give the patient steroids or stellate ganglion block, which is not without complications and all those things. So if the diagnosis is done, which is actually done by a radioisotope scan, it helps in two ways as I look at it. Number one, the patient also gets to know that what the problem that he has, and he gets reconciled to the idea of, that it is going to take a little longer time. And otherwise, just giving patients, some people even do methotrexate also for the treatment of those. So these are actually stronger medications and stellate ganglion and all those things. So that actually it gives a justification for the surgeon to be able to treat with those aggressive methods. But otherwise, yes, you are right. If otherwise, because the treatment remains the same, you can, the treatment is basically, as I said, physiotherapy despite the pain. And obviously, it is going to take a long time. The patient will take about 3 to 4 months to get back his movement, which otherwise you would have got in about a month's time with physiotherapy.
Okay, Professor Kotwal.
Sir, Dr. Manish, one second. Sir, in case if the old tier in the TFCC, so maybe we have realized with the help MRI that's an old tier in the TFCC. So should we treat it operatively, or should we leave it conservatively to the physiotherapy and bracing and splintage?
Your TFCC actually, if it is a longer ulna, is with one of the causes, then obviously the first thing would be to reduce the length of the ulna, and then depending upon the MRI, what the TFCC, if it is a peripheral tear or something, then one can repair, like classical treatment that you do normally you would do for a TFCC, or do an arthroscopy and debride the central foveal tears.
Professor Kotwal, ulnar abutment and impingement syndromes are same or different?
Good question. Ulnar, what I shown on the X-rays is the ulnar abutment syndrome. The impingement is different. The impingement comes after the direct operation, where the distal end of the ulna sometimes impinges and hits against the radius proximally. So that is actually impinging the radius, and that is called as the ulnar impingement syndrome.
Okay, sir. Ulnar impaction is also same thing. And ulnar impaction syndrome.
Impaction syndrome is the same thing as the impingement syndrome.
Okay.
Dr. Abutment is it is abetting. It is kind of hitting in every ulnar deviation.
Okay. Dr. Vikas, please be ready with your presentation.
Okay.
Any other question from panelists? We can take one question.
Can I ask one question?
Yes, sir. Yes, sir.
Kotwal, in any patient, can you give some indication initially whether this patient is likely to develop CPRS or may not be candidate for that? I mean, there is some indication before just the time when you start the treatment.
No, not really. Well, I'll answer that question as well. So normally the thing comes up after the treatment. You have removed the plaster and you send the patient for physio. He comes back to you after 2 or 3 weeks. And that's when you find that, he has little unusually more edema in the hand, or his movement, or the pain is not explainable, although the fracture you think is uniting now. And the pain is disproportionate to the time duration that he has passed and everything. So that is one indication. But otherwise, there are definitely there are many causes, and one of them is the psychological pattern of the patient. Some patients who are over anxious patients, or who have some psychological problem or some stressed out this thing, they are also more prone to develop CRPS. But generally that you cannot say in the beginning, but generally once the patient comes back to you after 3 or 4 weeks of removal of the POP and you find this thing, that's when you start suspecting that he perhaps is going into CRPS, and then you would investigate him or treat him accordingly.
Dr. Vikas?
Yeah.
Yeah.
Shall I share the screen now?
Yeah, sure.
Is it visible?
Yes.
Okay, am I audible?
Yes.
Okay, so good evening, friends, and regards to the DOA. I'm going to present a malunited forearm fracture in a 14-year-old boy. And it will be like a short case with brief history, examination, radiographic findings, and the management. So this was the child. So it's like a short case. You're given you see a child like this. So what history will come to your mind? So the first and foremost would be the mechanism of injury. And we all know that the commonest mechanism, the primary mechanism of injury is fall on the outstretched hand, which is also in a mnemonic form is known as whoosh. Okay. So most of the upper limb injuries in a child fall on an outstretched hand. Now in this child, the 14-year-old boy had a fall from a bike about 8 weeks back. So this is the history you must take. The second question comes whether the child had a previous injury, like he had sustained a fracture earlier also. And why this is important? Because among the pediatric fractures, forearm shaft fractures are the most common site of refracture, varying from 4 to 8% in varying series, okay, in different series. And important to ask, was there a bleeding? Was there a puncture wound which might have healed and which now the patient is not aware of? So history of open fracture or bleeding is also important. Now, this third question about the dietary and calcium intake may sound very strange, but like studies have shown, one of the paper actually has published that children, usually younger children between the age of 5 and 9, presenting with forearm fractures have lower BMD and lower vitamin D levels. So I think it's a good practice of asking the dietary and the calcium intake, especially in a younger child presenting with a forearm fracture. And last, the very important, what management has been done till date. Was the cast applied and how many casts were applied? Any other form of splint, which is very common in the country, whether a child had massage by an osteopath, and history of remanipulation, was the cast changed? So all these questions usually come to your mind when you see a deformed forearm, okay, or a deformity in the forearm. So now proceeding to the examination. So what all you do see? What you see is the level of the deformity and the direction of the deformity. Is the deformity in the upper third, middle, or a distal third? Also, this has a bearing in the treatment. We all know that fractures in the proximal third are more prone to redisplacement and are difficult to treat conservatively versus fractures in the distal forearm, especially in the pediatric population. So in this child, the deformity is in the middle third, and you can see clinically these apex volar. Okay. So now why this is important, like just I've told you that as the fracture moves proximally, there is increasing level of difficulty, especially managing these fractures conservatively. And most of these fractures which occur proximally, they occur in older children. Now, the second is you must see the skin condition like a normal examination. Skin condition, heel scar. Suppose if skin is scarred or there are other signs suggestive of infection, so your management can change. And then going from inspection to palpation, like tenderness, which may give a clue that fracture is still not completely united, local temperature, and forearm compartment, which are usually not tense in a late presenting fracture. Usually in acute fracture, you must look for compartment pressure also. And very important to look for bones and joints above and below the deformity. A child with forearm fracture may be having a subtle fracture in the distal humerus, like a supracondylar, which might have healed, or a distal radius fracture. So always palpate the joints and bones above and below the deformity type. And the last, movements. Now, this is where the most of the postgraduates actually fail to demonstrate. How do you demonstrate the pronation and supination? And they are using different kinds of methods. Now, the practical way is usually bend the elbow to 90 degrees, the arms by his side and forearm pointing directly. And a good practice is to give a kind of some kind of like a pen, so that acts like a arms of a goniometer. And the child is asked to pronate and supinate. So this is the way the pronation and supination must be checked. So in this child, you can see that the pronation was grossly restricted, and the supination, though it was restricted, but it was like almost normal. So we have these findings in this child: history of fall and a history of now there's a history of casting. Fair to tell you that there was a history of casting almost twice, and he was remanipulated once. And at present, the deformity is there in middle 1/3 with apex volar deformity with restricted range of pronation as well as supination. And there is no tenderness, no local rise of temperature, and the forearm compartment is not tense. And there is no tenderness above and below the deformity side. So how do you proceed next? So what most of the residents fail to do is now fail to check the neurovascular status. Now, motor, sensory, and vascular examination are equally important in forearm, as you see in a supracondylar fracture, although the neural injuries are rare. And even if they are there, they are mostly neuropraxias, which usually recover in few days to weeks. But make it a good practice. And in a younger child, remember these two tips and the two easy signs of doing thumbs up and OK sign. A thumbs up will definitely give idea of the radial nerve by extension of the wrist and thumb, and the median nerve by flexion of the digits second and third. The abduction of the digits will tell us about the ulnar nerve function, and the flexion of the index and the thumb DIP, like making a O, will give a function of the anterior interosseous nerve. Now, what about the sensory examination? You must know the autonomous zone and radial nerve for the dorsal first wrap space, median nerve for the palmar index tip, and the ulnar nerve for the ulnar side of the little finger. So make it a good habit of examining neurovascular status in every child. Okay? And coming to the radiograph. Now, again, I have seen the radiographs in which the elbow or the wrist were not seen. So always order or make sure that your X-ray includes elbow and the wrist, both AP and the lateral view, because their concurrent injuries might be there. Okay? Now, what do you see in a radiograph? First, you see whether it's a single bone or both bones. Okay? So in this case, there are both bone fracture. What is the level of the fracture? Proximal, middle, or distal third? And the pattern. Was it plastic deformation, green stick, complete, or comminuted? So in this case, it's a complete fracture in the middle 1/3 and in the both bones. So good way to remember is there are 2 bones, 3 levels, and 4 patterns. Okay, single bone, level, and the 4 types of fractures. In this way, you can remember how to write the X-ray findings. Now, in this child, so what are the findings? We see a malunited middle 1/3 fracture of both bones with volar apex angulation, then measured goniometrically is around 40 degree. The radial and the ulnar fractures are at the same level. So what does it infer? What do you gain from this? Actually, when the fractures are at the same level, one can reasonably say that the minimal torsional or rotational component at the fracture site. And we can see that interosseous space is grossly restricted and the loss of interosseous space. Okay, so coming to the fracture displacement, when you describe the X-ray, the treatment of the child's fracture is based on the 4 parameters, the displacement, and which can be described in terms of angulation, rotation, shortening, and translation. Now, angulation is easier to measure radiographically, especially if it is in one plane. What is problematic? The rotation seems a simple concept, but actually difficult to measure clinically as well as radiographically. I'll show you the few tips. Okay. So what do you see in a supinated AP X-ray? If you see a supinated AP X-ray, unfractured, you'll see that bicipital tuberosity points medially, and diagonally opposite, around 180 degree opposite, you have the radial styloid, which points laterally, and the radius and ulna are nearly parallel. So this you see in a supinated AP X-ray. Now, what do you see in a pronated AP X-ray? In a pronated AP X-ray, the bicipital tuberosity now moves laterally, and the radial styloid moves medially. So they actually move diagonally opposite. But what you see, radius crosses over the ulna, which is known as crossover sign. So this you see in a pronated AP X-ray. So I'll briefly tell you what is radius crossover sign, which we use to see the rotational malalignment. Now, just see this axis carefully. In an AP X-ray in full pronation, the radius actually crosses the ulna in the proximal 1/3. I think it's very apparent. In a neutral rotation, that is mid-prone, the radius crosses the ulna in a distal 1/3. And in a full supination, which we have just seen, the radius does not cross at all, and both radius and ulna are parallel. Okay, and you can see the bicipital tuberosity and the radial styloid, they remain diagonally opposite. So once you are clear about these two signs, bicipital sign and radius crossover sign, it is easier to judge rotational malalignment if it is there in the post-correction X-ray, post-casting X-ray. Okay. So just to take an example, now this green stick fracture of both bones, and remember this is the AP view. You see the distal humerus, it points the profile of the distal humerus. This is the AP view. And for a beginner or probably for a postgraduate, this will seem a normal, and he would pass it as a normal. But now, how do you check the rotational malalignment? The good practice is divide this X-ray into two parts. So let's see the proximal part. What do you see in the proximal part? If you remember the previous slide, where is the radius crossing? It is crossing in the proximal third. So the proximal fragment is in pronation. Now shift this, see the distal part. What is the position of the radius now? Just remember this previous slide. It's like a neutral rotation. Radius is crossing the distal 1/3. So the distal fragment is in neutral rotation. Proximal fragment is in pronation. The distal fragment is in neutral rotation. So what you see, there is a significant rotational component and with loss of pronation if this is allowed to heal like this. So this child would require pronation maneuver to correct this distal fragment so that both proximal and the distal fragment are aligned. Okay. So now coming to the management part. What should you do in this case? But first and foremost, what are the problems in the patient? Why are we treating this patient? He has a deformity, a cosmetic deformity, anterior angulation of about 40 degrees, and a significant motion loss, especially pronation. Okay, so the consequences of malunion are both cosmetic as well as functional. And how do we address this? We'll see. Okay. Now, before I go to this slide, our earlier surgeons, especially the More, he used to say that 50 degrees of rotation, that is pronation and supination, are sufficient for most of the activities. But I think this no longer holds true. We all know that in the digital era, we need almost full supination for holding our mobile and full pronation for typing. Okay. So any of this movement will be a functional deficit for most of us. Sorry. So the basic principle of management remains to accurately align distal fragment with the proximal fragment, both axially as well as rotationally. Now, see this X-ray, when this was aligned in a correct way, the fracture, and second important point is to maintain until the fracture heals. Not only aligning, but maintaining, because redisplacement is very common if the casting has been improper. So once this is maintained, the outcome is good like this with full pronation and supination. And for that, a resident must know the basic anatomy of the forearm, especially the muscular attachment. We all know the supinator attaches proximally, the pronator quadratus distally, and the pronator teres in the middle 1/3. So he must know the basic anatomy, pathoanatomy as well. And he must also remember that a child is different from adult, and there's a growth and remodeling potential, especially in a younger child, a child usually less than 10 years, which can remodel to a significant effect. So our younger colleagues must understand the basic forearm casting principle that the cast should have a good interosseous molding where coronal width should be more than the sagittal width, okay? And it should be around 0.7 or less. And the 3-point molding concept by Charley remains a significant maneuver to correct any kind of deformity, and the ulnar border should be straight. So these 3 points should be well remembered while you are giving a good forearm cast. And straight ulnar border is equally important, which is commonly ignored in most of the cast. A cast should be like this with an almost straight border, but we have seen a cast like this, which Wilkins has said like a banana cast, where well-reduced fracture can also displace like this, and the result could be both cosmetic as well as the functional loss. So coming to the management options, we have either we leave it, it may or may not remodel. Let us see. Remanipulate, osteoclasis, closed or using a drill osteoclasis, closed reduction elastic nailing, which is very popular in pediatric forearm fractures, and open reduction using plate fixation. Now coming to the first point, leave it and it might remodel. Some of you might think, our resident might think, let it remodel. But what are the factors affecting remodeling? Will it remodel? So based on the available evidence, based on the literature, it has been shown the child more than 10 years, in fact, girls in females, even more than 8 years, there has been incomplete remodeling. And the remodeling may not be sufficient enough to correct the complete deformity and the level of the fracture. A subphyseal fracture, a distal radial fracture will definitely remodel. In fact, this fracture remodel to almost straight radius, but a diphyseal fracture will not remodel, even in a younger child like this. So we know that this child is quite old enough for the remodeling. Now, another point is, what are the acceptable parameters of reduction? What should we accept in a younger child? Now, again, based on the evidence and based on the literature, it has been shown that maximum accepted is 20 degrees in the distal third and 10 degrees in the proximal third. So a proximal third fracture, you have to have a low threshold for accepting the deformity, and that too in a older child. Displacement, even that is a common problem among residents. They will see that the fracture is 100% displaced. This can still be accepted in a younger child if shortening is less than 1 centimeter. So 100% displacement can be accepted if there's a minimal shortening. And the last is rotation. A 45 degree of malrotation can be accepted, but again, the rider is defining rotation may be difficult in a younger child where bony points are not well defined. Okay, so in this child, would you like to wait? Will it remodel? Very unlikely, or I would say impossible. A 14-year-old boy with 40 degree of angulatory malunion and a middle third fracture. So this option is no longer left, that leaving the child as such. So coming to this point, a bit of theory. What is the effect of forearm malunion on the forearm motion? So it has been shown that 10 degree of malunion in either bone, like in this young boy, will have no motion loss or no significant motion loss, and he will have a good function. But vis-a-vis, a 20 degree deformity one or even both bones will lead to almost 40 to 50% loss of motion, both pronation and supination. Like in this young girl, which had a malunited fractures of both bone with significant motion loss. So we can accept almost 10 to 20 degrees at maximum in a single bone, okay? And that too in a distal fracture. Now, what about rotational malunion? Again, less than 45 degree of malrotation may have a little impact, but more than that, like in this child, will have approximately 50% loss of supination and pronation. And pronation can be compensated by shoulder movement, but for the supination loss, still there are no compensatory mechanism. So why there is a loss? If you see mathematically that the normal arc of forearm motion, as the radius rotates, it creates an arc, creates a cone, and a malunited radius, this cone is disturbed. This cone is no longer a normal cone, and hence there is a diminished arc of forearm motion. So coming to that next option, osteoclasis. Now, osteoclasis is a good option, especially in early malunion, a fracture presenting within 3 to 5 weeks. A fracture presenting at 8 weeks with almost the abundant callus, there is this closed osteoclasis bound to fail and may cause fracture at other region. And even drill osteoclasis is not a good option in this child. So what about the elastic nailing, closed reduction elastic nailing?
Dr. Vikas, please wrap it up.
Yeah, just last 2 slides. And you can see there's a significant callus, if you recall the x-rays, and with the blocking of the medullary canal. So elastic nailing is no longer an option, and that too, a closed reduction will not be possible. So the only option left is open reduction and the plate fixation. So this child underwent an open reduction with the plate fixation. Now you can see the photographs. This is just about 2 months back. Here, the deformity is fully corrected. The supination has been there, but still the pronation movement has still, he's doing regular exercise and pronation is still not there. But definitely, I hope that there will be improvement. There will be improvement in the pronation movement. And remember, friends, the loss of motion is not only due to ambulatory malunion, sometimes due to fibrous contracture of the interosseous membrane, which also leads to loss of rotation. Now, just the takeaway message: remember that normal child is not a miniature adult, and you should not treat a child's fracture like an adult. And their fractures are definitely unique, and most of the fractures can be managed by skillful casting. So what you must know is the mechanics of fracture reduction and the management. And remember, don't throw away the cast like this. And casting is still an acceptable form of treatment in a younger child. And at times, anatomic alignment is not crucial to a successful outcome. It may not be a good X-ray, but the outcome may be good in a younger child. And internal fixation is only reserved for an older child, especially in a proximal third fractures with unacceptable adduction, and at times when the conservative treatment has failed. Okay, thank you.
Thank you, Dr. Vikas. Professor Saket. Professor
Yes, Manish,
Saket, your comments or questions for Dr. Vikas Gupta?
I think Dr. Vikas has covered everything. Dr. Vikas, I just want to ask, would you like to consider the corrective surgery only if the angulatory deformity is more than 45, or depending upon the wish of the patient or demand of the patient, we would offer in less degree of the deformity also?
Even less degree of deformity. This child had a 40 degree of deformity, which is not at all acceptable. But any kind of deformity, like a visible deformity with loss of motion, I would definitely go for corrective osteotomy in an older child, where I won't expect any kind of remodeling. But definitely in a younger child with a lesser deformity, one can definitely wait for a remodeling, especially the fracture in the distal third. Okay.
If the child is more than 12 years or 13 years, do you consider grafting, or it is not required?
That depends on the stage of the malunion. And if in case, at times, actually, I don't need grafting because the bones and are coapted, and there has been an abundant callus which can also be used like a graft. So there are not many cases which undergo internal fixation in a child, but whatever I have done, there has been no need for grafting.
Thank you.
Okay, Dr. P.N. Gupta, you be ready with your presentation. Any other question from the panelist?
Can I ask you a question, Dr. Manish?
Yes, sir. Yes, sir. Dr. Sharad.
Dr. Vikas Gupta,
yes,
in this patient, suppose we just did would have done an osteotomy at the fracture site with a small incision and then fix it with elastic nails rather than putting plates, which would be causing more longer incisions and more morbidity.
You want to say a closed nailing?
Yeah, I mean, you do have to do osteotomy to reduce. I mean, to.
Yeah. But sir, can you see that X-ray? The medullary canal was almost obliterated. Okay. And closed nailing will not be possible. And I want to give a rigid fixation so that he can be mobilized earlier. So looking at this X-ray and his age, plate fixation is a far better choice than even doing open nailing, which may not be a stable fixation.
Dr. Vikas, I think we go to the next presentation. We'll take questions later on. Okay. I have not received question from the audience till now. Okay. Dr. P.N. Gupta. Dr. P.N.
Yeah.
Please share your screen.
Okay. So I'll do is are you able to see my screen?
Yeah, yes, sir.
Yeah. So sorry. This is I'll just go straight to the case. So this is a short case with the relevant history. This is a boy aged 5 and has presented to you with this sort of deformity and inability to walk since 1.5 years. And this deformity was noted since since 1 year back. I mean, not the age of 1 year, but 1 year back, since 1 year. So On further asking the history, patient had an injury while he was playing with his friends about 1.5 years back. He was taken to a local doctor where a plaster cast was given. And what else in the history you would ask for in such a child? That if the child had a fracture previously, similar fracture, or any history of fever or discharge associated with this injury. Now, if you see the history and the deformity like this, with the surgery being done, with plaster being given, and surgery being done, so one should always ask what further was done. Whether he was treated by a qualified doctor or a quack, and whether any other treatment was given. And in this particular patient, some sort of surgery was done 1 year back, where some rod was put inside his leg and removed after 3 months, but still he was unable to walk. And after that, he went to another surgeon who did some sort of fixator in his leg. Removed after 3 months, the leg became straight, but gradually it progressed to this sort of deformity. Now, once you see the patient walking into your or coming to your OPD, either on a trolley or the parents carrying the child with such sort of a problem, you feel that this is a child with a deformity where some sort of surgical intervention has been done, and there is a deformity. Now, what should come to your mind with such a deformity? There are 2 or 3 possibilities. One, that this is something, a united fracture. And what fracture would unite and cause a deformity in a 5 years old boy is usually something like a osteogenesis imperfecta, which can present with this sort of deformity. Or this is a fracture which is ununited, or this is a fracture which is associated with some sort of infection. Now, once you go for examination, on inspection, you see a anterior bowing and maybe you see a bit of lateral bowing also, but primarily this is anterior bowing. And this is a child with procurvatum at the junction of the upper 2/3 and the distal 1/3. And you do see a scar mark there. And you do see these multiple scar marks there, and these could indicate that some sort of perhaps Elizarov fixator would have been put with wires causing these multiple scar marks there. And this is a operative scar. I'm sorry, I don't have a clearer picture of this, but this, if you see, there is a linear scar, surgical scar there. There is no discharging sinus. There is no discharging sinus here. And if you see, there is a obvious shortening of this limb. And there could be some wasting there, but very difficult to appreciate. On palpation, there was no local rise of temperature, no tenderness. No tenderness means either this is a united fracture or it is a pseudarthrosis. If you see the measurements, there was a shortening of the limb by 5 centimeters and wasting of 2 centimeters in the calf muscles was noticeable here. Once some local area was done for some special tests were done, there was an abnormal mobility present at this area in both the planes, both anterior posterior and mediolateral. The distal neurovascular status is must here, and what do you evaluate in distal neurovascular status is the dorsalis pedis pulse here, the posterior tibial pulse behind the medial malleus on the affected side. This is the normal side, but you see it on the affected side. And toe movements, no, you don't see toe movements because most of the supply to the muscles has been given proximally here. So toe movements is not the way to see distal neurovascular status here, distal neurological status. But what is important is the sensations on the foot, on the dorsum as well as the plantar aspect. But once you do expose the child fully and do a general physical examination, you do see multiple spots which are cafeole spots. And here in this child, these are significant and they are multiple and they are big enough to be called cafeole spots. So more than 5 cafeole spots, they are basically indicative of a type 1 neurofibromatosis. So what comes to your mind here for the diagnosis? One, it is a congenital pseudarthrosis of the tibia, considering that there are cafeole spots. What else comes to your mind? Because now there is an abnormal mobility here, so fracture union is not there. So you don't consider osteogenesis imperfecta as one of the possibilities clinically. The second possibility still could remain some sort of infective pathology there leading to a non-union. So what you should do next here? So what, as Dr. Lalit Mani said, what investigations? I would say how do you manage this patient? Management means now you have to take care of everything. So what next you should do? You have to confirm your diagnosis. And how do you confirm your diagnosis? On the radiographs. And one should ensure that the radiographs, they cover an optimal area. And what radiographs do you advise are the X-rays of the left leg, AP and lateral view, including the knee joint and the ankle joint. Right. So what do you see here on these radiographs? On the AP view, you don't really appreciate much because there is a lot of overlap there due to the deformity. This deformity, if you notice, is around 90 degrees. But what you notice on the lateral view is a thinning of the end, sclerosis of the end, and both the bones are not united, and there is a atrophic type of non-union. And now what should come to your mind seeing this? There is no callus formation, there is no involucrum formation, there is no sequestrum. So what you should think of is a congenital pseudarthrosis tibia. Now why you should think of congenital pseudarthrosis tibia? Because normally in a child, the fracture of both bones leg is expected to unite. You don't expect non-unions in a child normally. So if a child is having a non-union or a pseudarthrosis, the first thing in tibia what should come to your mind is the congenital pseudarthrosis of the tibia, and especially if the patient has multiple more than 5 cafeole spots. So what is the diagnosis here? I think there is no confusion in the diagnosis. This is a congenital pseudarthrosis of left tibia in a 5 years old child. What is the evidence in favor of the diagnosis here? Ununited fracture in a very young child, multiple surgical interventions which have failed to make the fracture unite, anterior or anterolateral bowing, multiple or more than 5 cafeole spots, and X-ray evidence. What is the other type of bowing? What you see is a posterior medial bowing, and this type of bowing is usually benign and usually does not lead to a pseudarthrosis. So what you should do further in this patient? Well, there are many options. One is Ilizarov, where you resect the unviable bone ends, straighten the bone, and compress the bone. And in case there is additional shortening, you can do a corticotomy here and lengthen the bone. But the refracture rate is very high in these patients. So once you are remove the fixator, you must protect the tibia by an intramedullary device. Until what time you should protect is till skeletal maturity. What are the other options? Put in a straight rod either from the ankle or from the top. Straight rigid rod and bone grafting. And what sort of bone grafting? It should be a dual onlay cortical bone graft from the contralateral tibia, dual onlay or a triple onlay bone graft from the contralateral tibia, or else you can use cancellous bone graft which has been described by Dror Pele, where you can take a lot of cancellous bone graft from the iliac crest region. And one more thing is that if the fibular pseudarthrosis is present, you should fix the fibula as well. And aim for a cross union between tibia and fibula that gives you the strongest union. And in addition, once the pseudarthrosis has healed, you should protect this extremity in addition to the internal fixation with the external brace till skeletal maturity. So that's all what I wanted to discuss. So the options available for management treatment are Ilizarov fixator with or without intramedullary rod. After removal of the fixator, I would prefer putting an intramedullary rod or a rigid internal fixation where internal fixation of both tibia and fibula along with dual onlay or triple onlay bone graft, cortical bone graft from the contralateral tibia, or a cancellous bone graft, which is not preferred by many people, but this has been described with Dror Pele. Aim for a cross union between tibia and fibula. That gives you the strongest. So I think I end my presentation here. It's a short presentation, but I'm open to questions.
Yeah, thank you, Professor P.N. Gupta. Dr. Maninder, you be ready with your presentation. I have questions for Dr. P.N. Gupta. Dr. P.N. Gupta, do you wrap up the graft with periosteum also?
I used to do it earlier, but this was described by Dror Pele. I used to do it earlier. But honestly telling you, I have not been very happy wrapping the bone graft with periosteum, and I never found that this periosteum throws any sort of new bone in any of my cases. I have did it in a couple of cases and I have given up. And I have spoken to other colleagues of mine where most of the people have given up. Now for me, the best results for congenital pseudarthrosis tibia for union are with dual onlay or triple onlay bone graft from the contralateral tibia, where most of the patients have united. I would say about more than 95% of my patients have united with this.
Actually, we had a webinar by Professor Pele. I think you had also.
Yeah, I was also.
So he was telling that almost 100% with cross union. How much do you believe? Have you tried the cross union?
Yeah, I try to do it in most of the cases, but this was a question I asked Dror Pele, that in some of the cases the fibula is just like about 2 millimeters or 3 millimeters thin.
Okay.
So there it is almost impossible to go in for a cross union. But yes, if the fibula is of reasonable thickness, I do go in for a cross union.
Actually, one very common question is asked that when you do corticotomy, what level do you advise the corticotomy to be done? And is there any fear that corticotomy can also go into pseudarthrosis?
I have done a couple of cases, maybe around 15 or so. And this is the experience of my other colleagues as well, that unless there is a lesion proximally, which you can appreciate on the radiographs, the corticotomy does not go in for non-union.
Okay. Okay. But actually, usually they advocate a high corticotomy.
Yeah, I advocate a high corticotomy. But question is that sometimes, it's not possible in the cancellous area of the proximal tibia because there is a growth plate, especially in a younger child. So you need to go at the proximal, at the corticocancellous junction. Yes.
Professor P.N. Gupta, when you put a intramedullary stiff rod inside, do you also advocate a brace application till the maturity?
Yes, I told you it's still skeletal maturity.
And suppose this rod you have put it and the child grows, do you change the rod also?
Yeah, I change the rod periodically, as and when required. Yes. Recently, previously I've been putting rod from the calcaneum, but nowadays I go in for a rod from the top, something like a telescopic nail.
Okay.
So I put it from the top, from the proximal tibia.
But telescopic nail is not,
No, it's not strong enough, so I use a solid rod.
Okay.
With a threaded end.
Okay. Dr. Vineet, you had a question?
Thank you, Dr. Gupta, for nice presentation. Boss, I just want to know, is there any role of masculine technique in this kind of cases?
See, I'm not really aware of somebody doing muscular technique in these cases.
Okay.
And I agree with P.N. Gupta. We have not used this.
And do you advise that? Like, is there anyone who's
no, we don't.
The question is with musculae. I think I just read one paper for musculae, but the question with musculae is that most of the time what you use is a cancellous bone graft with musculae, and it is very difficult to procure cancellous bone graft in a young child, except if you are using Pellé's technique, and which at least I'm not very comfortable using, taking out the entire iliac crest region and splitting the iliac crest into two.
Professor P.N. Gupta, is there any role of BMP?
I really don't know, but I have not read any papers with regards to use of BMP. It's very, very expensive, and I've really not read papers in support of BMP.
We'll go to next presentation, but before that, Professor Saket, you have any question?
I think everything is covered.
Okay. Can we go to the next question, Professor Saket, next presentation?
Can I ask you a question?
By all means.
Yeah. Okay, Dr. Sharad, yes.
Dr. Gupta, what is the success rate in these cases now? We have been taught over the years to do whatever they don't unite. Even our experience.
See, one thing, since this was like a presentation to the students, now if you understand the basics of pseudarthrosis, one, that you have a faulty periosteum there. So that means whatever you call as a hematoma there is a faulty periosteum. And once the periosteum is lacking, that means whatever union you can achieve is always a primary union, not a secondary union. No callus is there. And for a primary union, what you require is a rigid fixation. And rigid fixation is always there with a strong rod. And another thing which has been associated with failure is that if you leave some sort of angulation at the fracture site. So again, that is keep on causing a stress riser, and eventually the implant and the bone will fracture. So if you're keeping the tibia straight, this is not likely to fracture. In my hands and in hands of a lot of colleagues of mine, I have found more than 95% success rate with dual onlay and triple onlay bone graft.
That's huge.
Yeah, it's a huge actually. I was initially I used to do Ilizarov, but the problem with Ilizarov was that it was a long fixator time, and with a lot of osteopenia occurring, and then you're scared to put in a rod because of the pin tract infections, which almost invariably are there in one or two pins. So I changed over to dual onlay, and if it is possible, if the bone graft is optimal, I put in three: one medial, one lateral, and one posterior stratal bone.
Dr. Sharath?
Yeah.
Dr. Sharath?
Yeah, please.
Just want to add that what we must prognosticate the parents is that the child may require multiple surgeries, and the success rate is more than 50% these days with the new techniques and the grafting methods. But whatever you do, you must protect the limb. I do Ilizarov in most of my cases, and I've seen the results are pretty good. I won't say 100%, but more than 50%, 60 to 70% success rate is there. The only thing is you must excise the hematoma, complete excision, and make sure that limb remains protected and splinted till he goes for skeletal maturity.
Fair point, I think.
Yeah.
Okay. Can we go to the
And
next presentation?
One more thing, just can
Yeah.
I add the last comment here?
Yes.
So you have to go in for a rigid fixation. That means you have to put in a very thick rod, as thick as the medullary canal can accommodate. That is going to give you a rigid fixation. If you put in a thinner rod, that's a recipe for failure.
And some kind of bracing also.
Yeah, bracing, of course, has to be
External
there till
bracing.
skeletal maturity. Yes, there's no doubt about that.
Thank you, Professor PN. Dr. Maninder, please load your presentation. Yes.
Okay, sir. Sorry, just a minute.
Dr. Maninder, be very crisp and short as a short case.
I will try to, sir, definitely. Sorry. Just give me half a second, sir.
Can I ask a question in the meantime?
Yes, sir, you can do so.
Dr. PN, should the candidate still read about the old techniques, the electrical stimulation, the McFarland graft and all?
No, I think they are given up. I mean, they are most of the times they are given up. They are just of historical importance.
The vascularized fibula
stimulation and McFarland bypass and all, they're just of historical importance.
Just half a second, sir.
See, what I think from the presentation I wanted was that the student should actually open up their mind rather than go in for a very fixed answers. They should open up their mind and go for a very rational way of thinking.
Actually, it is very rare to get a congenital disease arthrosis case, but sometimes yes, it can come.
Yes, I agree.
Dr. Maninder, are you ready?
Yes, sir.
Some problem is there?
Yeah, just some problem loading up the whole thing. It's just going to take half a minute.
And one more thing, actually, sometimes actually the students, they tend to misdiagnose this pseudoarthrosis. And what they have to remember that child, a fracture not uniting, we must consider to be pathological. So look for reasons for non-union. And one of the common reasons is pseudoarthrosis.
I fully agree with you, Dr. Vikas.
I think
I'm really sorry about this. Sorry. Okay, so can you see the screen now?
Yeah, we can see. We can see. You can continue,
Okay.
sir.
First of all, I'd like to thank Dr. Manish, Dr. Sharad, and Dr. Bajinder for inviting me here and the whole DOA team. It's been a really informative webinar till now. So hopefully I'll do justice to my topic. And I've been asked to speak on a short case of malunited ankle fracture. So when we take the history of a malunited ankle fracture, we have to really know what the problem of the patient is. Is that what is troubling him? What is the malunion that is troubling him? Is it the deformity or is it the pain? And whether he has any reduced function, whether he has any instability in the ankle or insecurity feeling, if he has any cosmetic problem with that, any footwear difficulties, and is he able to wear a shoe or not? And we really have to inspect the shoe to find out what is exactly happening. And we have to take the history of how he's worn shoes over after the injury. and the exact injury details and chronology is really important. How he actually got the injury, first of all, and then what was the subsequent treatment that was taken, whether he had any massage or any local massage done, anything to that. And that will tell us whether what exactly we're dealing with, whether we're dealing with any VIC or any compartment later on, or it's basically a malunited ankle fracture, which is the main problem. And in the history, it's important to know comorbidities which will affect the outcome of the treatment. And these are diabetes, peripheral neuropathy, any leprosy, spinal disorder causing neuropathy, any arthritis, any previous arthritis.
Mender, you are not audible.
I am not.
No, you are audible, sir. You are audible.
You are audible. Please go ahead.
Audible, please go ahead.
Okay, right. Thanks. So arthritis or any myopathy, which will affect the muscles or muscle wasting. So all these are important. And what are the disabilities the patient really can have? Disability in walking or of using, whether he's using a stick, whether he's able to sit cross-legged with the patient. Is he able to squat or not? Will tell us whether there's any ankle dorsiflexion and whether he can actually climb stairs up and down. So really ADL's daily living, we really need to know. And before we actually touch the patient, we have to localize the problem area. So basically with inspection, going to inspection, we have to think of standing gait analysis, single stance, tiptoe, step, double stance, tiptoe, balance, and walk on heels and lateral boards. I'll just show you what I mean over here. And so we have to assess basically the first is the shape of the foot. So if you look at it, whether the foot is actually going into a significant valgus, you can see over there, and this one is valgus as well, but this one's more, and there's a bit of deformity there which you can see. This one's into mild varus. So if you see, the normal should be a 5 degree of valgus in the heel at the back. If you look at exactly straight at the back, if it's completely straight, that basically tells us that there's slight varus over the heel there, and we really need. And if you see, this is a more obvious varus in the heel because of a malunion. And if you look for other things like a cavus foot, which may affect the overall picture of the malunion, and look at any forefoot deformities as well. So all these pictures will tell us whether there's any, any incident of the VIC or any other deformities, clawing of the toes, or if there's any sensory neuropathy which is affecting the, the toes. So again, all that is important, and it's the whole picture we're looking at. So looking at the gait, it's basically when we look at the gait, there are different types of gait. We all discussed that. But in foot problems, usually the gait is usually an adaptive gait. So the patient has the foot deformity, and then he adapts that to the. So there's usually an antalgic gait, but it's more of an adaptive gait, and it does not really fit into any of the classical hip gaits that we get. And so this is the single heel raise. So this what this test tests is basically the function of the tibialis posterior, and whether the subtalar joint, if you see, as soon as the patient raises the heel should go into varus, and that's really the important thing to see here. And the amount of times he can actually do this test is really important as we compare to the other side. This will tell us about the movement, the function of the muscles, and the strength. Again, now this is double heel raise. With this, basically, you can test both sides. You see the heel going into varus. This tells us that the subtalar joint is flexible. That is the main thing which we know from this test. So if you look at this patient here, you see the heels are straight, a bit of valgus both sides, and the valgus is not correcting on heel raising. So this tells us the subtalar joint is fixed, already fixed, the subtalar joint. So there's unlikely to be any movement in the subtalar joint. However, if you see this patient and you see this, after, and you can see the heels both going into varus nicely, and there's arch forming. So that basically tells us the subtalar joint is flexible, even despite the big deformity that is there in the ankle. So in the standing examination, we have to look for any calf wasting, any knee deformity, or any leg length discrepancy. And you can see in this patient, there's a compensatory, because of the knee injury and the calf injury that he has on this side, there's a compensatory flat foot of the foot. So it may not be necessary that the problem is in the foot itself. It may be some proximal deformity causing compensatory deformity in the ankle. And that's what we have to look for, is the whole exam of the foot. So standing exam, you have to observe the gait, standing position, and stand on tiptoe, which you already done, stand on heels. So basically, you have to do the ski stance or the squats. So if the patient can do that with the heel on the ground, then you know there is already some dorsiflexion in the ankle. If you can do the calcaneus gait, then you know that the Achilles is working well, the dorsiflexors are working well, so there's good balance. And then walking on the heels and tiptoes will tell you know about the peronei function and the tibialis posterior function, whether that is all okay, and the flexibility of the foot as well, whether the patient is actually able to do that. So now the examination is basically looking at palpation initially, and so basically palpate from top and going onto the ankle, going basically anteromedial first, and then going onto the central part of the ankle, and then you go on to the lateral part. Exactly the same level is the joint there on the medial and lateral sides. There's no tilt as such. And basically you have to look for any pain or tender points here. You have to look at the malleolar level. So the lateral malleus should always be lower than the medial malleus level. And that is really the important key point here. And you should palpate both the tendons, the peronei and the tibialis posterior to look for any tenderness in the tendons, so any tendinopathy happening because of the injury. There can be some impingement affecting the tendons, and that can cause more problems. And then palpating the whole thing, including plantar fascia. The next comes the anterolateral aspect, the syndesmosis. So this is the high ankle sprain. So if you look for any tenderness over the syndesmosis over the anterior side, and if there isn't tenderness there, then you know that that is syndesmotic area which is painful. Again, there is different tests for syndesmosis, which you can basically do a calf squeeze test or a direct pressure over the anterior and see for the fibular translation. And the other things, you have to palpate the peroneal tendons, see if there's any impingement in the peroneal tendons at all. And that's what you're doing at the moment here. And then medial side is the same thing. You're basically looking at the anteromedial joint, the tibialis anterior tendon, the tibialis posterior tendon, and the talonavicular joint, which is just there. And this is the intercuneiform joint. So palpate all through across the joints. And then we come to the movements. This is quite important. When we test ankle movements, whenever we dorsiflex, the ankle tries to go into external rotation. If we keep the heel stable with one hand and then do the dorsiflexion and plantar flexion, that's the accurate way of measuring the ankle dorsiflexion and plantar flexion. If the heel goes into valgus when we dorsiflex, then there is a pseudo dorsiflexion, which is not a true dorsiflexion occurring at the ankle, but that's actually external rotation occurring at the subtalar and the ankle combined. So you want to test the dorsiflexion, plantar flexion. This is a subtalar movement, so you stabilize the talus with one hand, and then you basically invert or revert the heel. This is the midfoot rotation, so you stabilize both the calcaneum and the talus, and then you do the midfoot rotations. This is the joint of the MTP joint. So you see the plane of the metatarsal is actually quite downward sloping, and that's how you measure. That's where you measure the ankle the MTP dorsiflexion and plantar flexion from, and not from the actual plane of the foot. So the metatarsal plane is actually quite high up as compared to the actual visual plane of the foot. And you test for all the other MTP joints to see the movements there. Now we have to test the muscle power, and that's basically not really relevant because we expect the muscle power to be normal, but it's just whether you want to test the peronei, the tibialis posterior, tibialis anterior, all the muscle power has to be tested really for an accurate neurological exam of the patient. So next is basically we are testing this peronei here, and so if we ask the patient to just lateral push and pull, and that will again tibialis posterior, and then peroneus brevis, the eversion, and peroneus longus will cause depression of the first metatarsal. This is the peroneus longus function which you're testing now. The eversion and plantar flexion of the foot is actually the peroneus brevis. So it's important to differentiate between these two muscles whenever we test for any muscle power in the foot. And then obviously the tibialis anterior and tibialis posterior function. This is the tibialis posterior, including plantar flexion and inversion of the foot. Now, these movements have basically the inversion and the eversion are used interchangeably with supination and pronation. It's very important to understand what supination and pronation is, because supination is a combination movement. So supination, as Dr. Matthew also discussed in the previous webinar, it is a combination movement of basically inversion at the heel, a forefoot adduction at the mid-tarsal joints, and it combined with the ankle plantar flexion. So it's a combination of three movements. Same as pronation is the outward movement, is the eversion of the heel at the subtalar joint, a forefoot abduction, and dorsiflexion of the ankle. So it's a combination movements which you have to understand. Really, these two. Silver test is very important for all ankle patients because we need to know about gastrocnemic tightness, and this will tell us how to do the silver test. So we know there's the differential dorsiflexion when the knee is flexed and the knee is extended, and if that is, it should ideally be the same. If there is difference, then you can know because you can see the heel pushes down as soon as you extend the knee, and that basically tells us that the gastrocnemius is tight. If it's the same in both positions, then you basically maybe the soleus is tight as well. So impingement test, again, very important for any trimallear fracture or any malunited fracture to look for impingement. There may be some osteophytes, or there may be some anterolateral anteromedial impingement because of OCDs, osteochondral defects, or cartilage defects. And we have to really understand that, sort of what the where exactly what is impingement. So impingement is basically if you palpate the anterolateral gutter and dorsiflex the foot. If there's increased pain in the anterolateral gutter area where you're palpating, then that is impingement, anterolateral impingement on the ankle. This is subtalar joint, which is very close to the anterolateral area. So it's really important to differentiate that it's not subtalar impingement. This is the anterocentral impingement, and then the anteromedial impingement is usually caused by. So anterocentral is usually by osteophytes. Anteromedial impingement is usually caused by either deltoid injury or by talar OCDs. So it's important to differentiate. And then we come to posterior impingement, which is basically pain at the posterior part of the ankle when we plantar-flex. So again, caused by posterior ostrigonum or epichyl injuries or epichyl tendinitis. And any posterior process fractures of the talus will also cause significant posterior impingement. It's important to understand all this. So obviously these things, other things which we have to, the local riser temperature, initially when you start palpation, the first thing, relation of malleoli to each other, we need to know that the lateral malleus is lower at about a centimeter as compared to the medial malleus. Whether we can actually passively correct the deformity or not. So if there's a valgus deformity, whether we can actually get that back to neutral or not, or whether this is a fixed deformity. So it's important to understand whether the deformities are the ankle or the subtalar joint, and we know about that by doing the movements of the ankle and subtalar joint. And you have to test for tibial torsion or any knee deformity or any hip deformity, which may be aggravating or correcting the ankle deformity in some way. So it's important to know the whole overall picture of the patient and whether there's any shortening as well. That's very important. So why do you want to know all this? Because it matters. Even a 1 millimeter shift in a malunited fracture of the talus in the ankle mortise causes a 42% reduction in tibiotalar contact area and it increased cartilage stress and wear. So we see that malunited fractures eventually will lead to arthritis if left over the long term, and that's what causes the morbidity in malunited ankle fractures. So, but there are no actual long-term studies to assess the outcome of malunited fracture. So treatment strategies, it requires restoration of bony and articular anatomical alignment. So basically that's our aim, to get it back to as anatomical as possible. So a common question which is asked is, you've had this ankle fracture 6 months ago. There's an intra-articular component of the ankle fracture which was displaced more than 2 millimeter, and there's a step in the ankle. It's now 6 months. Do you want to reconstruct it, or do you want to arthrodese the ankle? So the answer to that basically question is basically, if you'll see for any arthritis, and you can do an MRI if you want to look at more of the cartilage wear, and if there's no cartilage wear, there's no significant arthritis or any significant degeneration in that joint, evidence tells us that up to 2 years after a malunited ankle fracture which has malunited, you can still reconstruct the joint, and which is a successful reconstruction. In elder patients, you would want, see the patient as a whole, and you'd want a one operation which will suit everything. So you would want to maybe go for an arthroscopic ankle arthrodesis or ankle arthrodesis as a primary option in more elderly patients whom you'd want to do a single operation. But otherwise, it is for younger patients and who are physically active, you would want to get them, a restoration of the ankle alignment if possible, if there is no significant degeneration. If there's significant degeneration, then the option is basically arthrodesis. So malunion problems. What is the problems with malunion? So there is fibular shortening. So you can see this picture here, and basically what you have is that the fibular level should be about a centimeter long as compared to the medial malleus, and over here you can see that it's a pretty much same level. So this is not really a corrected ankle fracture. And fibular rotation, how can you tell whether there's a fibular rotation or not? So there's a coin test. Basically, if you put a coin here and make a line here, that's fibular length, and whether this fibula in the mortise view is matching up with the talus or not. That's very important. So, and if you see this medial opening, this is a giveaway sign for a fibular rotation. So a medial opening is not a sign of a valgus. It is a sign of a fibular rotation, which is causing the problem. So the talus is actually medially rotated, and that's why it appears opening on the medial side, So, the laterally rotated, so externally rotated, the talus, along with the fibula. And that's what causes the medial opening. It's not really the significant valgus that causes the medial opening. So it's more of the external rotation, which is not recognized. Syndesmotic diastasis can cause problems, as we know. Talar tilt, which we already talked about. So in this, obviously, the deltoid ligament is also gone, or a tibial malalignment, which may be caused by a pilon fracture or an intra-articular fracture of the distal tibia, or any extra-articular fracture, which can cause malalignment of the distal tibia, will cause tibia. So it's all the whole thing we have to look for. Radiologically, we have to look along the sentence line in the ankle as well. If you see this fibula line, if you see that this line doesn't match with the line of the ankle mortis of the distal tibial line, then the central line is broken, and this is a significant giveaway sign. You have to look for see this rotation. So if this fibula distal part matches with the talus, so this has to be a mortis view really to actually look at this, because the difference view will give a different picture. So, it's not necessary that if you don't see this exact picture in the ankle X-ray that there is a fibular malrotation. That's not true. You have to get the exact mortis view to look at this sort of configuration. And if it is a mortis view, you can compare with the other side and see whether there's any fibular rotation. To confirm, the best is a CT scan. Okay, the CT scan will exactly tell you whether the fibula is rotated in the mortis or not. And if you want to confirm anything in the ankle, a CT scan is a must. So what are the approach? You can have different osteotomies. You can do fibular osteotomies, tibial osteotomies, combined osteotomies, do fixation, internal fixation, external fixation, and a fusion. You can do a syndesmotic or an ankle fusion, and usually you require bone graft. So if we look at a couple of patients, this is a 12-week-old injury. So this patient is already united. She basically had a lot of blisters initially to start off with, and that's why she's not operated wherever she was being initially treated. You look at the fibular length here. It is very, very short. And you can see that the ankle is completely dislocated posteriorly, and there's a posterior malleus fracture as well. So this basically a 56-year-old. So three months down the line, you would want to reconstruct it. There's no loss of cartilage here, and she's likely to do well with the reconstruction. So posterolateral approach and a medial approach, and fix both the fibula, restore it to length. Does not require any fixation of the syndesmosis, as the posterior malleus was buttressed and the syndesmosis was stable. So you have to recreate the whole injury. If you don't recreate the medial malleus fracture and the lateral malleus fracture and the posterior malleus fracture, you have to recreate all three fractures first. Only then you will be able to move the ankle mortis. Otherwise, you won't be able to move it. Another patient, a 32-year-old male, very big patient, had this fracture. Was reduced closed initially into the ankle, and then had a fixation done. This was the X-ray we're talking about. This is quite short to start off with. Nothing was done, and then basically he continued to be in valgus. You can see the increased space medially, and that's the fibular length is quite short. You can see how many screws that is put in. Again, you don't require that many screws for fixation. 5 months down the line, still going into valgus, started weight bearing, and you can see the opening of the syndesmosis there. A CT scan confirmed that the syndesmosis is completely off. There's a small posterior malleus rim fracture, and you can see the increased space in the syndesmosis here. So this required something called a syndesmotic fusion, and we didn't try to sort of replace this thing. The fibula is still short, and I think that's not an adequate reduction here. So what we need to do is really do a fibular osteotomy and then lengthen and rotate the fibula so that you can close this gap. If you don't derotate the fibula, you can never close the medial gap, and that's really important point to know. And so coming to another case, a 26-year-old shopkeeper, he had an epiphyseal injury of the distal tibia, sort of intra-articular sort of fracture when he was 8-year-old, and then he landed up with this deformity. He's now 26, and you can see how much amount of valgus there is in this ankle as compared to the normal side. And really, he had significant deformity. So what we planned to do was an external external fixator correction, monorail fixator with corticotomy, because he was already 4 centimeters short on that side, and we did a medial closing wedge would have made further shortening of that limb. So we decided to do a lengthening on the proximal side and do a 1-stage correction of the lower side. of the lower, and then that gave us a reasonable satisfactory correction. 6 months down the line, he had reasonable callus at the corticotomy. It did not distract much, but overall he was happy. And you can see after removing the ankle alignment is restored. He's got a bit of procurvatum, but he's not worried about that. And from the initial position of deformity, you can see now that it is completely valgus as compared to the other side. It's pretty similar on the both sides. So it required a long time, but these take, obviously, as we showed in the previous cases where it takes a long time for these deformities. Now, this is an important case. Basically, this is...
Dr. Maninder, can you wrap it up? We have only 5
minutes. This is the last case, sir. I'm finishing after this. So, thank you, sir. So, this is a 32-year-old lady, 3 months post-trimallar fracture, treated conservatively. If you see the X-ray, it doesn't look too bad. The fibular length is not that bad. There's a bit of valgus. And if you, standing X-ray, you can see a bit of opening of the, but it's not that bad. But you can see this huge posterior malleus fracture. This is all healed. But if you see the position of the foot, you can see the significant valgus in the ankle there. And that's really an important point to note that, on the other side is completely normal and this is valgus there. You can't accept this. And if you see the CT scan, you see the syndesmosis impingement there. You can see the opening of the syndesmosis there, the significant displacement of the medial malleus, which is malunited, and the posterior malleus, which is malunited. So basically, they elected to do an osteotomy of the lateral malleus, oblique osteotomy, a medial malleus osteotomy. We didn't do anything to the posterior malleus, fixed both, lengthened it out. Because of the oblique osteotomy, we did not need to put an interpositional tricortical graft. But if you do a transverse osteotomy, then you will need to do a grafting from the iliac crest as well. And once that was restored, the length of the fibula was restored, valgus was restored, and then basically fixed it with a plate and then put some screws across and fix the medial malleus. And this is how she is. And she's now about 8 months down the line. She's doing really well. Everything is united. She didn't need any grafting at all because this is a locking plate, and we started weight bearing for her 2 months down the line. She's overall doing. The other option, as I said, is the transverse incision, and then you do a tricortical graft in that. So summary, you have to examine proximal to distal. You have to examine from all the sides, dorsal, sole, medial, lateral. Always look at the footwear, and you make a specific diagnosis and treatment for that. So thank you so much.
Thank you, Dr. Maninder. Professor Saket, your comments, please.
I think Dr. Maninder has covered it, not only for the postgraduates, but for the people who want to aspire for different kind of surgeries also. Wonderful, Dr. Maninder.
Thank you, sir.
Okay, and I think we have to wrap it up because we have exceeded almost around 1 hour. Any questions from the panelists for Maninder? I don't have questions from the audience at present. So any questions from the panelists?
Yeah, Dr. Manish, can I ask?
Yeah.
Yeah, Dr. Maninder, nice presentation, and we are really thankful for making us so comfortable with the old injuries. Maninder, is there any upper age limit for doing these kind of surgeries in these patients? Like, and the duration also, just like you said, kids for 2 years old, we can still do some treatment and all that. But in case of a patient with, in a government setup, we're getting a patient who are very old, like 6 year, 7 year old deformities, they are coming as childhood deformity coming in the adulthood. So should we operate them or should we leave them like that?
So I think the age is no difference. You have to look at the physiological patient, how physiologically fit he is. If he's a fit, active patient, you want to restore him back to his normal activity level, and that's our main aim. So even if the patient, you have to look at the osteoporotic level. So comorbidities, one thing which is in favor of fusion, if it's a diabetic, any neuropathy, you would want to do a fusion, okay? You don't want to reconstruct that patient because that reconstruction is likely to fail in neuropathy. But all other cases, even if patient is slightly osteoporotic, I wouldn't mind because we have now locking plates and they hold very well. So you can do a more rigid fixation, even an osteoporotic bone, and you get the patient, obviously we have to be sure that there's no degenerative changes in the ankle at that time when we actually want to operate. So if there's any degenerative changes, then you would do, arthrodesis. But no degenerative changes, no neuropathy, age is no matter.
Okay.
Actually, not the age exactly. What I mean to say is the
hello, sir.
Sorry, can't hear you clearly.
It already.
Dr. Ashok, We are
Yes,
just
sir.
wrapping up in a minute's time. Okay.
Okay, sir.
To know whether when the patient is already adapted to his deformity, so should we operate them still, or should we leave them like this one?
Yeah, we should, because we don't want that joint to become arthritic. It will, the altered biomechanics will load the joint eccentrically, and he will eventually become arthritic. And eventually they will require deformity correction as well as arthrodesis. At the moment, if there's no significant deformity, then you can just do, just correct that deformity rather than doing an arthrodesis. Much better for the patient.
I thank Professor Saket for remaining in this webinar for 3.5 hours, and in interest of the postgraduates. I really thank you, and I request Dr. Hitesh Lal.
Pleasure is ours. Thanks a lot, Dr. Manish and Dr. Sharad and Dr. Lalit Mani. And how is Dr. Shamsul's health now? I believe
He's fine. He's fine. Actually, this is the 5th day of MCT, and his father is also out of danger, wife, and all are okay. No problem.
all best wishes. Thank you so
And
much.
his child is also okay.
All our best wishes and prayers for him. Shamsul.
Yeah, don't worry, sir. We are taking care. Dr. Hitesh,
Thank you.
your final closing comments.
Yeah. Thank you. I'm thankful to Dr. Saket and Dr. Dakar for gracing this webinar. And it
Always
was
a
a very
pleasure.
nice teaching webinar on non-union, which is a short topic for PGs. They will get in the exam. And it was an amalgam of short and long cases. Very nicely done. And I'm thankful to Dr. Manish, Dr. Ravi, and OrthoTV for making this webinar happening successfully. Thank you all.
Thank you so much.
Thank you.
Thank you. And Dr. Dakar had he had to go to the hospital because Health Minister has, I think,
two of the
visited that.
ministers as a superintendent, he had to be there. Thank
Yeah.
you. I thank you all on his behalf as well.
Actually, I was born in the same hospital where Dr. Dakar is the medical superintendent. Yeah, I was born in the same hospital. Okay. Thank you. Thank you, everyone. Good night. Good night.
Right.